Good morning, everyone, and thank you for joining us. I'm Cheryl DeMars, and it's my privilege to be the President and CEO of the Alliance. We are celebrating our 30th anniversary, and we certainly wish we were with you in person. And I'll say this, I miss the energy, I miss the friendships, I miss the camaraderie. I miss the Monona Terrace granola bars, just saying. But there's advantages too to being virtual. It's a lot easier to get here. We have about 250 people with us today, and no one had to fight the Beltline or find a place to park. So welcome, and while we are doing our best to accept the things we cannot change for now, we certainly hope that next year at this time, we'll be celebrating 31 years in person. So a few logistics before we begin. You are all in mute mode, but we want to hear from you. So we invite you to use the chat feature of the webinar to ask questions or make comments along the way, and we will feed those to the presenters so that we can have some interaction. There are also handouts available in the handouts section of your webinar. You'll find the agenda and also information on our speakers and our sponsors. This is what you can look for, so you can see where to ask questions as well as where to access the handouts. And our educational program today will feature 3 speakers. The first is Chris Whaley from the RAND Corporation, and he'll be sharing information on a newly released study on hospital prices. Following that, we'll have comments from both Melina Kambitzi and Kyle Monroe, who will be sharing what we can do as employers working together through the Alliance to address high hospital prices. I also want to note that thank you to our sponsors, Delta Dental and National Cooperative RX. We appreciate your support and the relationship that we've had over the years. And I also want to note that we have another webinar coming up actually 1 week from today. This webinar will be about health policy topics, and we will have a couple of experts on hand, Elise Schumann and Katie Johnson from the American Benefits Council, who will be with us to share what the impact of the election might be on healthcare, what the positions of the 2 candidates are, and what we might see in the coming year in terms of regulations related to important topics like surprise billing and transparency and telemedicine. So it is now my privilege to introduce Wendy Culver. Wendy Culver is the chair of human resources at Mead & Hunt, and she's also our board chair. Wendy first served as the chair from 2017 to 2019, and she was pressed back into service this year when Larry Pribble retired. So we're grateful for your help, Wendy. Wendy's been on the board since 2008, and Mead & Hunt has been a member of the Alliance since 1993. Wendy is also one of the Alliance members who went with us to Washington, D.C. when the Alliance was invited to testify before the U.S. Senate Health Committee, providing insights about how employers are working to reduce healthcare costs. Our testimony, along with others, resulted in the introduction of the Lower Healthcare Costs Act. Wendy, we are so grateful for your support and your leadership. And on behalf of the members who benefit from that, thank you and welcome.
Oh, Cheryl, thank you so much for that wonderful introduction. I really do appreciate it, and I feel very humble to help out the Alliance for as long as I have. It's been a real privilege to be pressed into service. So thank you so much. We'll formally call the meeting to order virtually this time. Unfortunately, like Cheryl mentioned, we're doing this virtually. I think all of us probably thought that by this time we'd be back in person, being able to share wonderful things at Monona Terrace, but unfortunately that's not the way things went this year. So good morning to everyone, welcome. Again, it's been a real honor and a pleasure to chair the board. Since our previous board chair, Larry Pribble, retired last year, I hope he's having a wonderful time wherever he is. I know that you've all chosen a superb organization with the Alliance. Personally, for my organization, Meet and Hunt, working with the Alliance has been a great partnership over a lot of years. And I've been fortunate as a board member to have the opportunity to work with some extremely passionate and talented people who, like members of the Alliance, deeply, truly care about the state of healthcare and what we can do about it. So thank you all for being here. Now to a bit of business. I'm going to ask one member representative of each member company to participate in a quick poll in a moment. And please only participate in this poll if you are a member of the Alliance. So one of the things that we have to do at our annual meeting is to approve the minutes of the previous annual meeting. And so what I'm looking for at this time is, do I have a motion to approve those minutes? And I believe you should be able to unmute yourself if you're able to do that, to make a motion to approve the 2019 annual meeting minutes.
Wendy, we have a motion from Lisa Henke to move approval of the minutes.
Okay, thank you, Lisa. Do we have a second?
We have a second from Tina Hoig.
Excellent, thank you, Tina. Therefore, now we will have a poll put up on the screen, and members, if you could please answer that poll, that would be wonderful. We'll leave that open for just a few seconds. All right, let me know when we're ready to proceed. All right, the minutes have been approved. Thank you so much, everyone, for taking care of some of that business for us this morning. So the minutes have been approved. I'd like to just take a moment to mention new members. We welcomed 71 new members to the Alliance the last fiscal year, and we are super excited to see so many employers banding together to try and change healthcare. So on your screen is a list of the new members that have joined the Alliance. I'd also like to recognize that although our fiscal year ended in May, here we are in October already with more brand new members who joined us since May. So a big thanks to those organizations that just joined us. And of course, always thank you to our existing members. It's your membership in the Alliance that gives us all a stronger voice to help make real changes in healthcare. The next thing that I'd like to talk about are our elected board members. And as you know, I mentioned earlier, Larry Pribble of TROCT retired as chairman of the board, as well as retiring from TROCT. Like I mentioned earlier, hopefully he's off enjoying himself. Last November, we elected Jake Nolan of Rice Lake Weighing Systems to take Larry's seat. And we're so very glad to have him with us on the board. And additionally, Tina Hoig of Advanced Laser in Chippewa Falls, Wisconsin, was just voted in at our last meeting as a new board member as well. So congratulations to Tina. And again, thanks to our members for using your voice to vote and participate in the cooperative. We've been fortunate to add both Jake and Tina to what was already a very talented and diverse group of folks on our board. Our board members are Diana Clark, and if we were in person, I'd ask them to each stand up, but unfortunately we can't do that to recognize them. So Diana Clark, Mick Gronewald, Richard Campbell, Lisa Henke, Brad Ohm, Craig Parsons, Kyle Reading, and Shirley Rife. It's truly been a pleasure working with all of them, all of these wonderful professional caring individuals. And thank you so much for your service and for your contributions to the Alliance. Our board is completely volunteer, so that really tells you how these folks are extremely dedicated to and passionate about our mission. And we see that every day with members of the Alliance. It has been a wonderful relationship, and I hope we continue to move forward with that. So with that, I am going to introduce Paul Meyer, He is our Chief Operating Officer here at the Alliance, and he also serves a dual role as Board Treasurer. So I'm going to turn it over to Paul. He'll provide us a report on the financials for the past year. So Paul, take it away.
Good morning, everyone. Thanks, Wendy, for your remarks and your introduction, and for your service to our Board of Directors. We certainly appreciate your help and guidance, so thank you. I'm pleased to once again be presenting the Treasurer's Report. Before I get to my prepared slides, I'd like to briefly remind you all about the ownership structure of the Alliance. You know, the formal business name of the Alliance is the Employer Healthcare Alliance Cooperative. I want to spend a second on the cooperative part. A co-op is a type of corporation where its members own the company. When an employer, the member, joins the Alliance, they become a partial owner of the company. They elect a board to represent their interest in working with us, the CEO and the staff, to meet the needs of the membership. The profits of the company are generally not taxed. They are distributed back to our members. This form of a corporation was chosen by our founders to assure that we're focused on serving our members, not investors and remote shareholders, which is often the case for other vendors that you may hire. This is an important distinction in our market where healthcare providers deal with many outside organizations. For example, health insurance companies, many of which are very large companies, headquartered far, far away. Healthcare providers know that when they're dealing with the Alliance, they're dealing with local employers, unencumbered by mixed incentives. In other words, it's clear that we work for you. Our membership purchases close to $500 million in healthcare. We're obviously an important part of the market, that's for sure. So being organized as a co-op, very much a unique characteristic of the Alliance. I'm here today as the treasurer, giving a financial report to you as owners of our company. You're going to hear me today talk a lot about the impact of COVID-19 on our financial performance. We're no different than most companies. COVID has presented its significant challenges. On the upside, we were and are well positioned financially to weather the storm. So as I said, I'm presenting to you as an owner. And if I'm an owner, let me just advance the slides. If I'm an owner, I want to know how are we doing? Our revenues covering expenses. This slide shows the revenue and expenses by fiscal year for the last 10 years. The tall bar is revenue, the next bar is expenses. The difference between the two is net proceeds or profit. Our fiscal year is June 1. So for example, FY20 was June 1, 2019 to May 31st, 2020. You can see that revenue bumped up to just over $8 million in FY20. This is primarily a result of member growth, as Wendy showed you on previous slides. The increase in expenses over the last couple of years is primarily the result of this growth, also filling some key organizational positions and making investments in our analytic capabilities. In FY20, as you can see, we experienced a slight loss. You can see expenses exceeded revenue by a slight bit. Early in the fiscal year, we were cruising right along, financially doing well, and then the pandemic hit, and it hit us financially starting in about mid-March. What you need to understand is that our revenue is directly tied to the amount that we save our members through our contracts. We keep a small portion of the savings that result from our provider contracts. If people don't seek care or can't access care, which was and still somewhat is the case, then there are no savings being generated through the contracts. From mid-March to the end of May, which were the last 2.5 months of our fiscal year, we saw a decrease of about 25%. People largely stopped seeking care and providers were limiting the type of care they would provide. This had a corresponding impact on our revenue and resulted in the slight loss for the year. Like most companies, we had to learn how to do our work differently, meaning in a remote work environment. I am so proud of our approximately 40 employees and our business partners who were patient, smart, helpful, committed, loyal to help us make this transition and do it in a secure manner. We remain working mostly in a remote environment right now. If there's a silver lining in all of this, it's that we now have new ways to meet our needs and your needs. So a big shout out to our team and business partners and you all to sustain us as we all get through this pandemic together. So thank you. Before I leave this slide, I want to mention that in a normal year, we would have a profit. And I would explain that in the co-op world, we would be paying out some of that profit to our members. This is called patronage of the cooperative. Unfortunately, since there was no profit, there will be no patronage this year. This is a graph based on our balance sheet. It's a snapshot in time of our books as of the end of the fiscal year, which, as I mentioned, is May 31st. It shows total assets, liabilities, and the difference, which is equity. Overall, what you're looking at is the balance sheet of a very healthy company. Assets exceed liabilities by a healthy amount. With respect to FY20, you can see a significant increase in our liabilities. This is related to the Payroll Protection Program, or PPP loan, that we took. This program, sponsored by the federal government, allowed companies impacted by the pandemic to get a forgivable loan from the government as long as the dollars are used to cover payroll and other limited expenses. We chose to pursue such a loan for about $775,000. We're required to show the PPP amount as a loan, which means it's a liability, and that's why our overall liabilities went up a corresponding amount. At the point that this loan is forgiven, it's recognized as income, and we will book it that way. We are in the process of putting through our forgiveness application. Expect that the full $775,000 will be forgiven. It's a good time to mention that our board hires an audit firm to audit our financials on an annual basis. Like all other years, we receive assurance that our financial statements are an accurate portrayal of our financial position. To a large extent, our success depends on us being a significant part of the healthcare market. We have grown from the original 7 employers who helped to form the Alliance to now 295 employers, representing about 109,000 people in an Alliance affiliated plan. We purchased over 400 million, closer to 500 million in healthcare services last year. With this kind of membership, representing this kind of dollars, we're definitely a significant player, have the attention of the market. While our profit was off this year, the increase in membership from a financial perspective is a strong indicator of longer term success for the Alliance. It's like when you hear another company saying that profit was off, but fundamentals were strong. In our case, it's the membership that's fundamental. This graph goes to the heart of a very important component of our mission, and that is to help our members control costs. This graph shows the medical claims costs after our contracted rates are applied, associated with providing care to the over 100,000 people enrolled in an Alliance affiliated plan. It's calculated by taking all the claims we received for hospital, clinic, and ancillary services, applying our contracted rates to get a net amount, and dividing it by the average number of people enrolled in an Alliance affiliated plan. In FY20, the amount was $471 per person per month, covered by an Alliance affiliated plan. We could spend an entire day talking about cost drivers, etc., and they won't let me. I'd love to. Our goal is to help you manage this cost. You can see the increase back in FY15 and 16, with moderation in FY17 and 18 and 19, and then a decrease of 5.1% in FY20. Normally we would be celebrating, but what we need to know is the primary influencer of this reduction is healthcare utilization. As I mentioned earlier, utilization was off by about 25% over the last 2.5 months of the fiscal year, as people's willingness to seek care was reduced and providers' willingness to provide it was also reduced. This is the biggest reason for the decrease. We're seeing this turn around early in this fiscal year. More care is being provided, but we're a bit uncertain of the sustainability of that turnaround as COVID seems to be spiking again. And we're uncertain of the long-term impact of people not getting the care they needed in a timely way. That's all I have for prepared comments regarding our financials. To summarize, the pandemic impacted us financially. We remain in a strong overall financial position. We continue to bring value to our members. I'd like to thank you for your membership in the Alliance, and thank you for being with us today at the meeting. Cheryl, are there any questions that were posted through the WebEx?
No questions at this point, Paul, but certainly if anyone has questions in the future, please reach out. Paul would love to hear from you. So thanks, Paul.
Sure.
And now I'm clicking through my slides. All right, well, like many of you, during the pandemic, we've spent some time cleaning out drawers and closets and kind of freshening things up a little bit. And so did the Alliance. And you will begin noticing a slightly different logo for us. It's cleaned up a little bit and fresher. And with this, you'll see new clear messages in the market in the coming weeks and months. And we want to note that while we may look a little different from a logo standpoint, our mission is the same as it's been, which is to help you control costs, improve the quality of care, and engage people in their health. And over the course of the next couple of hours, you'll hear from us what you can expect to see in the future by way of a sharper focus on helping you maximize the value of our network. These efforts are all summarized in the tagline, Self-Funding Smart. So first though, I'd like to just provide you a brief update on some recent health policy work that we've done, and also talk a little bit about this topic that's so central to our mission, and that is transparency of healthcare information. The lack of our ability to measure and compare price and quality in a very publicly accessible way is one of the cost drivers in healthcare. This is part of the problem. We can't manage what we can't measure. But this is beginning to change. The curtain may be lifting, and we are helping that along. The Trump administration, for instance, recently released rules requiring hospitals and health plans to publish their prices, the prices real people pay for services and coverage. And while these rules have a long way to go and are facing stiff opposition from those who, quite frankly, benefit from the status quo, there's also a groundswell of support for transparency and progress being made through public sector efforts like ones you'll hear about today through the RAND Corporation. I want to point out something important, and that is that as members of the Alliance, you already have an advantage in this area in that you have access to the prices we negotiate on your behalf already. This whole topic of transparency and the work occurring in the market, either through regulations or through the private sector, have caused us to conclude that we need a formal position on transparency. Here's an illustration of what I'm talking about. What you're looking at here is real data. This is the price of an MRI within a 50-mile radius of Rockford, Illinois. And you can see on the screen, the price varies, the real price people pay, from about $530 to almost $5,500. We could have drawn this chart almost anywhere in the country. This level of variation in pricing exists everywhere. Imagine what would happen if we were to move the care that we're buying from high-priced providers to lower-priced providers. The size of the dot on this chart represents the number of MRIs that we're buying at each priced facility. And you can see we're buying a lot of $3,000 MRIs. We don't have to. We can use transparency of information on prices to move care to providers that do a good job and cost less. That's why we've taken the step of drafting a resolution, which we've asked you to vote on in the last couple of weeks. We think it's important for the Alliance to take a formal position on transparency of negotiated prices. And I'm happy to report that you agree with that. This resolution passed overwhelmingly. And so now we have a formal position in favor of transparency of negotiated prices. This is important so that we can speak with one voice authoritatively on behalf of Alliance members as policies get made, as healthcare debates occur, and as initiatives like the RAND Corporation's Employer Price Transparency Study make their way through the market. This is important to you as employers because it helps you fulfill your fiduciary duty as a plan sponsor. Transparency of price and quality is also important because we can't, without that, really do value-based purchasing. And finally, we know that shining a light on transparency or making these prices and making price and quality transparent and publicly available creates accountability, which creates a change in the right direction. When we put together this resolution, we did so through numerous conversations with our board and staff and Health Policy Committee. And along with this public position, we also want to make clear there are certain design considerations that are important. And the first is to have a standard definition of price. We think it's important that if the curtain goes up on negotiated prices, we're able to look at those prices and make sure that we're making an apples to apples comparison, that people are defining price in the same way. The second design consideration is that while price is important, so too is quality. And we will be advocating for much faster progress to make important quality measures publicly available so that we can use price along with quality to make a more informed decision. And the third design consideration is that transparency alone is not enough. It's up to us to use the information to make decisions about who to include in a provider network, about how to pay for care, and about how to structure benefit plan designs to encourage people to go where care is good and costs are low. Transparency is the first step, but it's just the first step. If this kind of work, if this type of conversation is of interest to you, join us. We are now recruiting new members for our Health Policy Committee, and I'd encourage you to let us know if this is something that interests you. The requirements are that you be an Alliance member and that you have an interest in healthcare and health policy. You don't have to be an expert. We just want you to be at the table, contributing to the discussion, and occasionally, when it's appropriate, weighing in by writing a letter or signing on to a letter, making a phone call or meeting with a legislator to let them know your point of view. The voice of employers needs to be heard in healthcare. So if this is something that interests you, I'd encourage you to contact me and we can get you involved. It's now my pleasure to introduce the educational portion of our program, which focuses on the RAND study. This, I want to just explain, is a unique study for several reasons. First, this is a national effort that sheds a light on the real prices that the commercial market is paying. It is independent and objective. The RAND Corporation has a 70-year history of doing objective analysis to help inform policy and decision making. And the data comes from us. It comes from employers across the country. It comes from all payer claims databases. And it's funded through employers as well as grant funding. So both the data source and the funding are unencumbered by traditional industry influences. The results, as you'll see in a minute, will help us gain new insights and ask better questions than we've been able to do before. So here to share those results and do a deeper dive in Wisconsin and Illinois is Dr. Chris Whaley. Chris is a policy researcher at the RAND Corporation and professor at the Party Rand Graduate School. His research focuses on using large-scale medical claims data to examine how information and financial incentives influence a patient's choice of providers, how providers respond to changes in consumer incentives, and how employers and insurers can design insurance benefits to promote value. It's now my pleasure to introduce Chris. Chris, thank you so much for the work that you're doing. Thank you for the time that you're taking to explain the results, not just to us, but around the country. And I think Chris probably feels like we have him on speed dial, given the number of calls that we've had over the last week or so. Is speed dial still a thing? I don't know if it is. Anyway, Chris, thank you and welcome.
Great. Thank you for inviting me, Cheryl, and for organizing this event. Before getting in, I just want to make sure that everyone can see my screen, you can hear me, and all that stuff works well. So are we good to go? All right. So now that we are great. So again, thank you for having me, Cheryl, and excited to share work and actually to kind of complete a bit of a feedback loop. So this is the third round that we've done this study. We did the study last year and had really a pretty small slice of Wisconsin data, and so actually we're not that confident at all in our Wisconsin results, or limited confidence. This year, where I met with you all in May of this year and explained that the study and some of the things that we're trying to get out of it. And you Wisconsin employers really, I think, met the challenge, and actually the state of Wisconsin is the state where we have the most participation from employers. And so I think this year, the advantage is that the study results we have this year are much more reflective of the prices that Wisconsin employers are paying. And so just a few acknowledgements. So as Cheryl mentioned, this study was funded by the Robert Wood Johnson Foundation, which is a philanthropic organization that invests in a lot of healthcare and health services research, and also by participating employers. And so we gave employers an option to see kind of under the hood for their own patient populations and their own employee populations. And that support really helped drive the study. This is a study that actually came out of an employers organization, the Employers Forum of Indiana. And so we've tried to really have a good connection to employers throughout the course of the study and for the last couple of years. And then I also had a really good opportunity to work with some great individuals at the RAND team. And I'm sure if you sent us data or interacted with us, you may have interacted with some of our team members. And so just for some framing and why I personally think this is an important question, in the United States, employers provide health insurance for about 160 million people. So this is roughly half of Americans receive insurance from an employer-sponsored insurance plan. Collectively, employers, and I think more importantly, their employees, pay about $1.2 trillion in healthcare costs, with about $500 billion of that going to hospital care. And so we're going to focus specifically on hospitals because that is the largest chunk of the pie for employer-sponsored spending. And so employers in the United States really fund the US healthcare system, but as we're going to talk about, maybe don't have great insights into where their dollars are going. And if we look at prices paid by employers, we know that employer-sponsored plans are paying a lot for healthcare. And in particular, if we look at hospitals, we can see that in the blue line, prices paid by employers and other private insurers for hospital care for the last couple of years have been higher than the prices paid by Medicare, the orange line, and Medicaid, the gray line. And in addition, the gap between the prices for hospital care that the private employers are paying and that the public payers are paying has diverged over the last couple of years. And so there's a growing concern that maybe there is unanticipated cost growth for employer-sponsored plans. And so that's great. The prices are going up, and that's an interesting finding, but I think we have to not take that in a vacuum and not think about just healthcare costs by itself, because employers really pay for healthcare costs out of wages and other types of benefits. And so this figure shows results from another study that we had this summer, where we looked at trends in inflation adjusted wages, so that's the blue line, and trends in the inflation adjusted amount that employers spend on healthcare costs. And so this includes premiums, worker contributions, copays, et cetera. And so if you look at the blue line, the take-home pay for the average American worker over the last decade has actually been flat. Healthcare costs for employers have increased steadily. And so I think there's a growing concern that wage stagnation for workers is really driven by increases in healthcare costs. And so as we're thinking about moving the economy forward, I think that's a challenge, especially when the current environment we're in, where there is a particular pressure on many employers and workers. And so if we look at the landscape of what we already know and think about what's already out there, we know that, as I showed earlier, private plans or prices paid by private plans and employer plans for hospitals are high and growing faster than Medicare or Medicaid rates. If we look at other studies, there's a lot of work that suggests the differences in spending between different regions are really driven by differences in price growth and not differences in healthcare utilization or patient mix. And then we also know that prices vary from market to market, and then even within a market from hospital to hospital. But I think that there's a lot that we do not know. And so one, how do prices actually compare across the country? A lot of the data that has looked at healthcare costs and hospital costs has used data that is a little bit older. And so we don't know how trends have evolved over the last couple of years. We also, I think, particularly relevant for purchasers, don't know exactly what hospitals or systems are getting the highest prices and which hospitals and systems are getting paid lower prices or negotiated lower prices and thus might be a better value. And I think this point is particularly important because many of the existing work and study on healthcare prices has just looked at broad regions and hasn't been able to actually name specific hospitals, which if you're a payer is something that's critical to do. And so I think the overall piece that we don't have a good sense on and that we really need to fill is what are the prices that you as individual self-funded employers are paying? And are these prices in line with the value that you and your employee populations are getting from hospitals? And if you're thinking about purchasing healthcare, this is something that I think is absolutely critical to know. And I think it's not just important from a purchaser standpoint, but also I think there's actually a pretty strong responsibility to take action on how your dollars are being spent. And so if you look at the Department of Labor regulations, employers who offer insurance through a self-funded model have a fiduciary responsibility to act solely in the interest of plan participants and their beneficiaries, and with the exclusive purposes of providing benefits to them. And so there is a legal obligation to make sure that healthcare dollars are being spent wisely and that you are getting the most value for your dollars and that your employee populations are benefiting from your health plan choices. And so if we're thinking about the role of a self-funded employer as a purchaser, how can they maintain this and fulfill this fiduciary responsibility without knowing prices? And so if you're to look at purchasing any other aspect, in order to say whether or not you're getting a good deal or not, you have to know how much you're actually paying and what prices are. I want to recognize that this is a particularly challenging time for both employers and the health system. And so we know that the COVID-19 pandemic is placing a tremendous amount of pressure on both hospitals and employers. Hospitals and health professionals are critical and vital members to communities, and we need to make sure that they stay in business and that they maintain operations. At the same time, for many employers, health benefits are their second largest expense. And so I think that now more than ever, when many employers are also struggling financially, employers and the health system broadly needs to have transparent information about prices. So given the challenges that both employers and hospitals are facing, I think now is not the time to run away from new information, but rather to embrace it. And so given that, that background, why did we get interested in this study? And so I think, you know, one thing to clarify is as we're going through the data and looking at variation prices, we as researchers can't say what the right price for any given employer is to pay for healthcare. Rather, what we intend to do is to give self-funded employers information that allows them to act as responsible fiduciaries for their employee populations and give them the price information that allows them to take control over their benefits. And so what we really intend is that employers use this information in the report that we provide, together with the knowledge of their own employee populations, their own markets, to decide if prices that they are paying actually align with the value that they're getting. And so we can't make these choices for you or tell you whether your prices are too high or too low, but rather can give you information about prices and allow you as an employer to make those decisions. We, as I said earlier, that we've done the study for a couple of years. So first we just looked at Indiana. This is what we call RAND 1.0. Last year, we expanded it to RAND 2.0, which included data from 25 states, including a handful of data from Wisconsin, which we've really been able to expand upon this year. That year, we looked at data from health plans and also a few all-payer claims databases, and focused mainly on hospital inpatient and outpatient prices. Where we are today is that we've been able to get data from 49 states. We excluded Maryland because they have a unique all-payer rate setting model, and so hospital there actually have much less price variation, or rather employers pay the same rate as other public payers. And in this round of the RAND study, we're able to get data from many employers, health plans, and 6 state all-payer claims databases. We included data on inpatient and outpatient prices, or inpatient and outpatient hospital services rather, and included both facility and professional fees. And another addition that we also have in the RAND report is we also looked at procedure level prices. So we looked at prices for a few large ticket items. I'll describe some of those in a minute. As we're thinking about the study, comparing hospital prices is a challenge, largely because if there's lots of data involved, and how you actually do it can be a bit tricky. And so I'm going to describe kind of broadly how we went about the study. And so the first step, as I mentioned earlier, was just to actually get data in-house. And so we did lots of events to speak with employers and health plans and get them interested in the study. And we're able to get data from a number of employers, some health plans, and as I said earlier, all-payer claims databases. We measured prices in 2 different approaches. The first approach that I think is going to be the easiest to interpret is relative to Medicare. And so this is how much do employer plans pay relative to what Medicare would have paid for the exact same services at the exact same hospital. And our second approach is a price per case mix weight. And so this is essentially a dollar amount that doesn't adjust relative to Medicare. And I'll describe both price measures in more detail in a couple minutes. Our main study output is a public report. This is downloadable on the RAND website, or if you email me, I can send you a copy. And then so the public report describes kind of broad price trends and differences in prices, and I'll describe this in a minute. And we also looked at data on self or individual employers or rather individual hospitals and facilities, and actually named them in supplemental material. And the public report and on both the public report and the supplemental material focus on inpatient and outpatient prices. And then as I mentioned earlier, we also have a private report option. And so this is an option that individual employers can get to see data on their their employee populations. And so if there is this broad public report that's available to everyone and pools data across the country, I think that's informative for how we think about prices. But if you're an individual employer and want to see exactly how much you are paying and your employees are paying, then we have this private report option where we just look at your data. And so as I touched on earlier, when we're thinking about comparing prices, this is something that is not entirely straightforward as how to do so. And so if you look at it, kind of the range of hospitals, every single hospital is very different. They treat different patient populations and do widely different services. And so if we were just to look at, say, an average price across hospitals, it would be pretty misleading. And so what we decided to do in the study is really leverage the Medicare system as a way to benchmark and to standardize prices. And so this is we use the Medicare system and a lot of the methodology developed over the several decades in the Medicare system to make more of an apples to apples comparison that allows us to compare one hospital's price to another hospital's price. And so, like many things, there's more than one way to accomplish the same goal. And so we actually have two different approaches. And so we call this making an apple pie, but using two different recipes. And so our first approach, and the one that I think is kind of the benchmark or the bedrock approach, is the percent of Medicare. And so the way to interpret this is how much do employers pay for the exact same services at the exact same hospital relative to what Medicare would have paid. And so this is essentially just a price ratio that it tells employers how much more or less are they paying relative to what Medicare would have paid for the exact same set of services. I think that the advantage of this approach is that it's pretty easy to interpret. So if you see that one hospital is charging 300% of Medicare, another hospital is charging 200% of Medicare, that's an easily comparable number. It's also comparable across service lines. And so if one hospital does lots of outpatient services and one hospital does lots of inpatient services, we can pool the two and just get kind of a single number for each hospital. And I think it's also useful because the Medicare system over the decades has really spent a lot of attention thinking about how much more it costs to provide healthcare in different hospitals and in different regions. And so the Medicare system, for example, pays hospitals in higher priced areas or areas where it costs more to hire doctors and nurses, higher rates than areas that are less expensive. Likewise, if a hospital has lots of uncompensated care patients, then that hospital gets paid more under the Medicare system. And so this percent of Medicare way of looking at prices bakes into itself all of these Medicare specific adjustments that the Medicare system has developed. Our second way of looking at prices still uses the Medicare system really as a kind of a way of looking at prices, but is not relative to Medicare. And so instead of saying what's a percent relative to Medicare, we instead are going to use the Medicare system as a way to benchmark and to standardize prices and get an average dollar amount per admission. And the way that I tend to think about this is that Medicare over the decades has not just figured out how much it costs to provide care in different hospitals, but at the individual service level, how much more it costs to provide treatment. And so one of the challenges we have when we're looking at hospitals is that, let's say, one hospital does lots of MRIs and one hospital only does knee replacements. If we're just to look at the average price, then that's going to be pretty misleading. And so what Medicare has figured out is for individual services, how much more it costs hospitals to provide those different services. This is a relative price measure, a relative intensity measure that's been developed over the decades of the Medicare system, and has also been developed with a lot of input from industry and other stakeholders. And so it's not like Medicare created this in a vacuum, and there's actually been lots of feedback from a variety of people in the healthcare systems. And so, for example, one way to think of this is that the Medicare system and Medicare reimbursement rates are exactly 34.65 times higher for a patient who receives a heart transplant than for a patient who shows up at the emergency department with chest pains. That makes a lot of sense. It costs a lot more to treat a patient for heart transplant and to perform that surgery than to just treat a patient with chest pains. And so we're going to use these types of weights to make apples to apples comparisons and to adjust for different services that different hospitals do. And we're going to use this amount, or this approach rather, to calculate what we call the standardized price, which is equivalent to the walk out the door amount after adjusting for all these differences across patient populations. One disadvantage of this is that the Medicare case mix system is quite a bit different for inpatient and outpatient services. And so we're actually going to calculate a separate inpatient and a separate outpatient standardized price. The other, I think, advantage of this is that many employers may not want to pay hospitals more for all of the other things that the Medicare adds in. So, for example, teaching hospitals, so academic medical centers get paid slightly higher prices than the non-academic centers. Disproportionate share payments, so uncompensated care payments, etc. All of those get baked, as I said earlier, into the Medicare payment formula, but don't actually get included in our standardized price metric. And so just to be clear about our comparison to Medicare, we are going to leverage the Medicare payment system as a benchmark and not as a price endpoint. And so to be clear, we are comparing prices relative to Medicare, which allows both a comparison to the largest purchaser of healthcare services in the world, but I think more importantly, actually allows a common benchmark and a common denominator to compare different hospitals. And so, as I said earlier, we can say that one hospital is 300% of Medicare and another hospital is 200% of Medicare, and that's an easy way to compare whether one hospital is more expensive than another hospital. I think we're not saying that all employers need to go right to 100% of Medicare, just because that's something that's not actually relevant to or related to that comparison between hospital prices. And it's also important to recognize that the Medicare benchmarking system probably isn't entirely perfect, but it's hard to think about what is another system that is a better one to use. And so I think the real advantages of the Medicare system are twofold. So one, as I mentioned earlier, it's really been developed over the last couple of decades with a tremendous amount of input from industry and other stakeholders. And then two, it's also transparent. And so maybe there are other kind of black boxy type approaches that might be a little bit more nuanced or better in different areas. But the advantage of the Medicare system is that everything is online. We or you or anyone else can go to the CMS website and download exactly how Medicare pays for different services. And so I think that transparency is really important when we are comparing such an important service. And just a quick note on data protection. So this study was overseen by the RAND Human Subjects Protection Committee. Everyone who handled the data had to undergo pretty extensive human subjects training and data security compliance training. And we actually analyzed the data on the same environment that RAND uses to analyze confidential Medicare data. And we also put in place a bunch of non-disclosure agreements and data use agreements to make sure that confidential data is protected. All right, and so what did we find? So I think the top line number is if we look broadly across the country and we look at the price trends for the amount that employers and private health plans are paying relative to what Medicare pays for hospital care, that amount has increased pretty steadily over the last couple of years. So for example, if we go back to 2016, employers and other private health plans were paying prices that were 224% of Medicare. That increased to 230% of Medicare in 2017, and in 2018 jumped to 247% of Medicare. And so across this time year, this 3-year time window, that's about a 5.1% increase in prices relative to Medicare per year. Another thing to keep in mind is that this is relative to Medicare. Every year, Medicare adjusts prices to account for inflation. And so this gap is on top of what's already an increasing Medicare payment rate. Another thing that we looked at is just the variation across states. And so the relative price of 247% is not the same in all states. And so if you look at states like Arkansas and Michigan, the price for inpatient and outpatient services, which is the red square here, is actually below 200% of Medicare. On the other end, if you go to states like South Carolina or West Virginia, the relative price for employer plans approaches 350% of Medicare. And so in the United States, just state to state, there's almost a 2x variation in prices from the top to bottom. If we look at the two states that are particularly relevant for Alliance members, Illinois and Wisconsin, we find that prices are towards the upper end, but not nearly as high as states like South Carolina and West Virginia, and at about 275% of Medicare. As I mentioned earlier, we looked at facility prices and professional prices. And so this chart shows how much, or ranges in facility prices. And so this is how much how much hospitals get paid for a given hospital stay. Here we find a similar range as I reported earlier. And so facility fees account for about 15% of hospital bills across each state. And again, states like Rhode Island and Arkansas are below 200% of Medicare. States like South Carolina and West Virginia are at about 350% of Medicare. Wisconsin is in the middle of the pack at about 250% of Medicare or slightly above, and Illinois is a little bit more expensive at just under 300% of Medicare. When we look at how much professionals get paid, and so this is doctors and nurses who provide hospital care, the rankings and the story really flips. And so we still see a pretty wide range in prices, but the ordering of the states is quite a bit different. And so when we look at states like Delaware and Kentucky, health professionals get paid about the same amount by private plans as they do from Medicare. States like Minnesota and Alaska, professionals get paid almost 400% above Medicare. Wisconsin is actually number 3 in our professional fee ranking at about 350% Medicare, and Illinois is towards the middle of the pack at about just under 200% Medicare for professionals. We also looked at the gap between professional fees and facility fees by state. And so you can see in some states, the professionals have a higher price relative to Medicare than facilities. And in many states, it's actually the facilities who have a higher price relative to Medicare than professionals. In Wisconsin, professionals have a higher relative price than facilities. And in Illinois, the story, like many states, is the opposite, where facility fees are higher than professional fees. We also looked at variation in prices within state. And so this plot shows the minimum at the bottom. The shaded bar is the range between the 25th and the 75th percentile, and the top bar is the maximum price within each state. And so if you look at variation within states, one of the surprising things to us was that within a given state, there's often more variation in prices just within that state than if you were to compare prices across states. And so I think what's really important for employers, or the takeaway from employers, is that as we're thinking about price variation, in many cases, it's not necessarily the comparison of say, looking at prices in Arkansas or West Virginia or South Carolina. In many cases, it's actually looking within your state and identifying the hospitals that are near you that are high priced versus low priced. We did the same exercise for health systems, and so this chart shows the health systems in our data that have at least 10 hospital systems, or 10 hospitals in their systems rather. And we found that within health systems, there's also a wide variation in prices. And so this is also surprising to me, because I, going in, thought that health systems would try to push prices towards about the same amount. But we're actually finding pretty wide variation in prices within systems. And so I think, the takeaway from employers is, if a given system is in network for you as an employer, the price you're getting for that's hospital within the system may not be relevant or related to the other prices within that same system. We also looked at quality, and so to look at quality, we used two metrics. So we, on the left-hand side, used CMS quality star ratings, and on the right-hand side used leapfrog safety scores. And so the CMS star ratings go from 5 stars, which is the highest, to 1 star, which is a low quality hospital. And the leapfrog grades go from a grade A, which is a really safe hospital, to an F grade, which is a unsafe hospital. For our two different quality measures, we categorize hospitals as low price. So those are hospitals that are less than 150% Medicare. Hospitals that are medium price, so those that are between 150 and 250% of Medicare, and those that are higher priced, which are those above 250% of Medicare. For each of our price definitions, or each of our quality definitions, we find that there is some relationship between price and quality. And so if you look at say example, the CMS grades, or the CMS stars, we do find that there are more 5- and 4-star quality hospitals in the high price versus the low price bar. However, if we look at leapfrog grades, the differences are a lot smaller, and we find many hospitals in both measures that are in the low price category that are either 4 or 5 stars or have an A or B grade. And at the same time, we find many high price hospitals that have either 1 or 2 star and have a D or F grade. And so I think that the takeaway from employers is that, or for employers rather, is it's not sufficient to look at just kind of hospital price or quality for the sector as a whole. It's really a story of individual hospitals and how do price and quality vary hospital by hospital. And so I think it's important to have individual level hospital data on both price and quality. And then the last high level finding that we looked at was the relationship between a hospital's share of public patients, so this is Medicare and Medicaid, and their price. And so we looked at this largely from the feedback that we got last year from our report, where we did not look at this relationship. And so one of the pushbacks that we got largely from hospitals last year was that hospitals have to charge higher prices to employer plans because they're underpaid by Medicare and Medicaid. Now, if that is true, then we should see that hospitals that have a high share of public payer patients, so a lot of Medicare and Medicaid patients, are the ones that are charging the highest price. And at the same time, we should find that hospitals that have lower shares of Medicare and Medicaid patients actually have lower prices. And so if that story is true, then on this chart, we should see more or less a increasing trend line, or the dots cluster around a 45-degree angle line, indicating that higher price hospitals have more public payer patients. Instead, if you look at this, it's hard to make any patterns out of this, and it's essentially a random splatter of dots. And when we actually look a little more in depth in the data, we find no relationship between a hospital's share of patients that are from either Medicaid or Medicare and that hospital's price. And so it doesn't appear that hospitals are shifting costs to employers, but rather there are market-specific features that allow hospitals to charge high prices. And so I think that the takeaway from that, or the more simpler way to say that, is that if a hospital is charging high prices, would charge that same high price regardless of how many Medicare or Medicaid patients that hospital had. And instead, when we look at what drives prices, it's actually not cost shifting to employers, but it's rather the fact that many hospitals have, say, a high reputation that allows them to charge high prices, or they're in markets where there's just not a lot of competition. And so those are our high-level findings. And so I wanted to dive into some Wisconsin and Illinois specific findings. And so as I mentioned earlier, one of the really nice advantages of our data is that we're actually able to name individual hospitals in health systems. And so this figure shows hospital systems in Wisconsin and the range in prices that employer plans are paying. And so if you look at the health systems in Wisconsin, employer prices are ranging from about 175% of Medicare for hospitals that are independent and not part of a health system, all the way up to 400% of Medicare for the Mayo Clinic. The state average is in the light blue line at just under 300% of Medicare. If we look at Illinois, we find similar trends, and so Advocate Aurora is about 200% Medicare, and UW Health is at about 350% of Medicare. If we look specifically at inpatient prices, we find really similar trends, and so the previous two charts were inpatient and outpatient combined. Here we find that for inpatient prices, independent hospitals that are just under 150% Medicare, and Mayo Clinic is just under 400% Medicare. And so going back earlier to where I talked about the two different definitions of price, you can see that here. And so the bars are the percent of Medicare, but then the red line is the standardized price that doesn't calculate relative to Medicare. And the standardized prices are displayed on the right axis. And so the red line corresponds to the number on the right axis, the dollar numbers. And so here, if we look instead of a relative to Medicare amount, we see that the standardized price for inpatient hospitals for an inpatient discharge is just under $20,000. And on the other hand, the Mayo Clinic is almost twice as expensive at about $35,000 per inpatient discharge. And if we do the same for Illinois, we find that Advocate Aurora has a relative inpatient price of just under 200% of Medicare and a standardized price of around $20,000. The variation is a little bit less than Wisconsin. UW Health has a relative price of over 300% of Medicare, but a standardized price of just under $30,000. I mentioned earlier that we also looked at orthopedic or individual procedures, and so this just highlights that for orthopedic procedures. And here we find that in a relative term, orthopedic procedures, so things like knee, hip, spine replacements, etc., range from about 130% of Medicare all the way up to just over 300% of Medicare. And in a standardized price, range from under $20,000, about $15,000, up to just under $50,000. And so, as a lot of the orthopedic procedures are shoppable, and so it may be important for employers to think about this type of range in prices for shoppable procedures, and think about if there are high quality providers towards the lower end where you can direct patients using steerage programs. And if we do the same thing for Illinois, we had less data for Illinois, but we still see the same range in prices. So in relative terms, orthopedic or inpatient orthopedic procedures range from about 135% Medicare all the way to 250% Medicare, and standardized prices reflect the narrow range and range from about just over $10,000 to about $28,000. If we look nationally, so this is combining all the hospitals in our data set, we see the similar range in price variation that I displayed earlier. So on the low end, inpatient orthopedic procedures are about range from about $7,700 all the way up to just under $115,000. And so a lot of that data is all on the RAND website if you want to look at different procedures. So we have a host of other procedures that we calculated prices for and name specific hospitals and health systems by name. And one of the pushbacks of this study has been that our results are from a very selected sample. And I think it's true that we do just have data for the employers that participated, and so it's important to compare our results to other settings and other studies. And so I think there are really three good ways to do that, or three other studies that are good benchmarks. One is the what's called the Healthy Markets Report from a group called the Healthcare Cost Institute. This is another research organization that really focuses on healthcare costs and healthcare data issues for the privately insured market. And so what they do in their Healthy Markets study is look at different metro areas. So I think they rank about 150 metropolitan areas in the United States and rank their prices from high to low. And so, for example, if you look at Sheboygan, Wisconsin, they rank Sheboygan as the 4th most expensive metro area in the United States. Green Bay, Wisconsin is the 5th most expensive. Milwaukee is the 7th most expensive. Racine, Wisconsin is the 8th most expensive. And then going just downstate or across the border to Chicago, they ranked as the 56th most expensive, so pretty close to the middle of the pack. Rockford, Illinois is the 65th most expensive. Another data set is a recent study published by Michael Chernow out of Harvard University, which used data from the IBM Market Scan claims data set and looked at the state level prices relative to Medicare. And so what they found was that Wisconsin was the 6th highest state for the gap between private plans and Medicare plans. And Illinois was the 22nd highest. And so Illinois is, again, right in the middle of the pack. And then the final source is the Medicare cost reports. And so this is data that hospitals have to report to Medicare as a condition of treating Medicare patients. And so every single hospital in the United States that treats Medicare, which is essentially all hospitals, report this cost information to Medicare. And one of the kind of really detailed things about the cost reports is that hospitals have to report their relative revenues and standardized prices for commercial patients and Medicare patients. And so we've actually used that data to calculate at the state level what's the average relative price to Medicare between private plans and Medicare, rather, again, using data that hospitals self-report for all hospitals in the US. And so if we look at this data, Wisconsin is actually at the top of our list, and Illinois, again, is right in the middle of the pack. And so as we're thinking about kind of our study in relation to other studies, I think it is true to acknowledge that we do have data from the set of employers who wanted to know this information and who participated. And it's true that we don't have data from employers who didn't participate. And so we can't necessarily say broadly, what do states, what do things look like outside of our data set. But if we compare our study to other studies, the findings that we find, at least for Wisconsin, actually tend to be a little bit lower than what other studies have found. Like other studies, we find that prices in Illinois are pretty much in the middle of the pack compared to the rest of the country. So that's a very high level overview of what we've done and what we found. And if there are specific questions on individual findings, happy to answer those in the questions or offline later. But next, just wrapping up, I want to kind of talk from a little bit higher level on what can you actually do with the data and how other employers actually use this type of information to create change within their employee population. And so the way I personally think about how employers can and have used this information is it's really kind of a continuum of policy options. And so on the kind of the initial phase, many employers are excited just to have information about prices and the prices that they're paying, and really for the first time to see this information. And I think one really good example of this would be the Colorado Business Group on Health, which actually used this data to create a value report for their employers or their member employers that combined our price data with some pretty detailed information on the quality that they have from their own metrics, and then use this report to discuss different policy options that employers have to think about changing prices, or also even approaches that the Colorado legislature might take. And so a lot of those initial ideas that the Colorado Business Group on Health proposed in that report are things that are just starting to gain steam now. A second approach is to actually use this data to benchmark prices. And so I think one example of this actually comes out of Indiana, where the employers from Indiana who really reached out and created, you at least got the momentum going behind this report, used the data that we reported for outpatient services in Indiana, where we found that outpatient prices vary even more so than they do in Wisconsin. And so what the employers from Indiana did is they went back to their various TPAs and said, look, we don't want to be paying this level of price variation. And instead, what we'd like you to do is to design a network for outpatient surgeries that caps prices at a relative price of 200% Medicare. And so that does two things. One, it brings prices down considerably. And so before prices in Indiana ranged from around 200% all the way up to 400% and 500% of Medicare. And so just having that 200% of Medicare really does a good job of bringing down those upper prices. And then two, it just makes the life of those employers easier to make sure that they're getting a deal or prices that they're happy with. And so if employers essentially turn the price negotiation process over to insurers and third-party administrators and brokers without having any insight into the prices that are being negotiated on their behalf, then we end up in the situation where prices are all over the place. And so benchmarking prices relative to Medicare is a way that employers, I think, pretty easily can have a little bit more control over the prices that are being negotiated on behalf of themselves, and more importantly, their employee populations and their families. And then I think the next step on this approach is to actually think about hospital networks. And so some hospitals in the we talked about and that we have in the data are pretty higher priced relative to other hospitals. And I think a particular example of that is in our report last year, we actually highlighted a particular hospital and health system, the Parkview Health System in Fort Wayne, Indiana, as being among the most expensive hospitals in the country. And so employers in Fort Wayne, Indiana saw that and were essentially not happy about paying the highest prices in the country and possibly the world for hospital care. And so actually went back to their TPA and said, look, we're not happy about the prices that you have negotiated. And we want you to actually go back and negotiate a new contract, or we're going to go to a different TPA. And now that we have information about prices, we're actually going to use that information to hold our new insurer to account on prices that are being negotiated on our behalf. And so that whole process led to actually a new contract being negotiated, which reduced healthcare spending, or is projected to reduce healthcare spending by $700 million for Fort Wayne, Indiana employers. And so I think that's an example where using price information and demanding a little bit more accountability on prices that are being negotiated on your behalf can be something that leads to pretty substantial changes in the market. And so that's issues that employers, or actions that employers can take rather. But I also want to acknowledge that there are markets where maybe employers need a little bit of help. And if you look at the same Healthcare Cost Institute group that I mentioned earlier to highlight the prices in Wisconsin and Illinois, they've also looked at how markets are varying in their competitiveness across the country. And so if you look at the same set of markets that they looked at, and you apply kind of the models of competition that regulators like the Federal Trade Commission or the Department of Justice use for market competition, and other markets like hotels or grocery stores or cable, et cetera, they actually found that in 70% of US markets, the hospital market in that market is actually above what we consider a non-competitive market or a dominated market. And so there are some markets where employers just simply may not have lots of options. And so if there are only a handful of hospitals in your given city, or maybe even only one or two, then it's really hard for you as an employer to implement a lot of these steering programs. And so I think there are a few options that employers can really get behind. And so one is pushing for an all-payer claims database that really allows employers, policymakers, and others to really highlight a lot of the variation in prices and really think about how to address these prices. And so I think in the state of Wisconsin, there's a voluntary APCD, and so I think that's a really good first step. Then I think there are also policies that can promote competition, and so think about policies that actually try to increase the level of competition in these areas where there's only one or two hospitals in a pretty wide radius of care. And then if you look at one of the reasons that many employers actually haven't been able to get good information about prices, or why there aren't many so little price transparency, is that many contracts between hospitals and insurers actually have pretty strong gag clauses in place that prevent any type of price disclosure. And so I think kind of negotiating in that type of secrecy is something that really does not benefit both employers who are paying the bills and their patients or their employee populations. And so I think pushing to get rid of those clauses is something that could be important. And then also thinking about limiting out-of-network charges. And so this is something where there's been a lot of activity recently at both the federal and the state level. And I think addressing out-of-network bills could actually have a pretty strong effect on reducing in-network prices through making the insurance contracting system a little bit more transparent. And then finally, thinking about either all-payer or global budget programs. I mentioned earlier that we didn't even include the state of Maryland because they put in place a all-payer budget or rate-setting program in the 70s. And that type of program really serves to eliminate a lot of the variation in prices that we see. And so with that being said, I think that there are still a few questions that we don't have good answers to. And so first, our most recent year of data is 2018. Obviously, a lot has happened since then, both in 2019, but then also more specifically what's happened with COVID. And I think how COVID has impacted prices that employers are paying, and especially the fallout and the aftermath of COVID, isn't quite clear. I mentioned earlier that there's a lot of concern that variation in market structure and market competition leads to differences in prices. And so I think that's something that could certainly could be pushed in and explained a little more. And then finally, I mentioned earlier some of the programs that I think really innovative employers have implemented. So for example, the benchmarking system in Indiana. And I think examining what types of smart things that employers have done in measuring kind of in this kind of laboratory of ideas, what works best relative to other ideas, and allowing employers to learn from other employers is important. And so with that in mind, we are planning in the early phases of planning for RAND 4.0. And there's actually a link to this website, which again, happy to share later, to get on our mailing list and to learn more about our next steps. And so just to wrap up, and some final thoughts, rising healthcare costs place a tremendous amount of pressure on employers and their populations through lower wages. And I think this is especially true during the COVID-19 pandemic, when I'm sure that many employers on the phone are dealing with essentially the most difficult challenges that they've faced in their professional careers. The wide variation in prices, especially for hospital care, presents a really important potential savings opportunity for employers. And employers, I think, can use that variation to think about ways to send patients from higher price hospitals and move them to lower price sites of care. More importantly, employers need to, I think, do a better job of demanding transparent information on the prices that they and their employees are paying and that are really being negotiated on their behalf. And then related to the comment on variation in prices, I think employers can really use innovations in benefit design and strategy to save money and to get a little bit more value for what they're paying. Thank you, and happy to answer any questions. And my contact information is here if you have offline questions.
Chris, that was an amazing presentation. Thank you, and what great data. Raises so many questions. I'm going to start with a broad one, and then we'll get to more specifics. So the first question is, what was the most surprising finding for you from the study?
Yeah, that's a good question. So there were many surprising things. And I think the two most surprising things were, one thing that just continues to be surprising is just the range in prices in different, within the same market and within the same states. And I think that really is, it's both surprising, but I think it's also really important for employers, because it suggests that if you're paying high prices, it's not a given that you need to keep paying those high prices. And in many cases, there are alternative places that are nearby that are offering prices that are literally half the same price. And so it's kind of like the Geico, 15 minutes could save you 50%. I think thinking more about prices or just looking at the prices in your market could save you 50%. And so just the level of price variation in hospital care is always surprising. The second thing that was really surprising was the cost shift story. And so going in, I actually thought that we would find some evidence that higher prices are in fact explained by higher Medicare, Medicaid patients at a given hospital. And so to find that there's actually no relationship at all was actually surprising to me.
Yeah, that was, if I could just comment as well, that was a surprise to us as well. I think for years we've heard that that hospitals don't have a choice but to shift costs to the commercial market because the public sector payers, Medicare and Medicaid, aren't paying their fair share, which for starters assumes that healthcare is already as efficient as it possibly can be, which I don't think anyone would say is true. But then to find no correlation really was a surprise.
Yeah, and I guess on that point, just to push on that a little bit more. So the whole argument of the cost shift story really revolves around hospitals leaving money on the table. And so if hospitals are pushing the cost shift story, a question is if you were to have fewer Medicare or Medicaid patients, would you lower our price? And I think the answer to that is no, we've got to keep our price, regardless of what our patient population looks like or case mix looks like.
So, Chris, I'm going to ask a specific question now, more of a methodological question that you touched on briefly, but maybe you can go back over. So, the question is, for the data in the study, what is this representative of the whole? And what's the confidence level around that?
Yeah, so I think a couple points. And so for the employers who participated, our data represents 100% of your data and the prices that you're paying. And so if you're an employer and you're thinking, how does this translate to the prices that I'm paying? I think the answer is it entirely translates and represents all of those prices. And if you're thinking about comparing this to the broader market, frankly, last year we had data from southern Wisconsin, but really not much from the rest of Wisconsin. And so the fact that this year we were able to get such a robust participation from Wisconsin employers, I think makes us really confident that our results are in line with actual prices that people even outside the study are paying for healthcare. And I think that the other point to mention is that I think the comparison to other studies and kind of triangulating is also important. And so if we were to find results that are vastly different from the other studies that have used different data sets and different approaches to look at prices, then I would be concerned. But the fact that we're actually finding almost the exact same prices for both Wisconsin and Illinois makes me pretty confident that the results that we're finding are in fact accurate.
Thanks. I would also just add, this is something we can do something about. And we saw, as Chris mentioned, in the second round of the study, there wasn't a lot of Wisconsin data. We, through the Business Healthcare Group, our sister coalition in Milwaukee, and Wisconsin Manufacturers and Commerce and the Alliance teamed up to spread the word about participation in RAND 3.0, and employers responded. And we can do even better for RAND 4.0. It's free to participate, and you can send your data in. That brings me to another question, Chris, which is, so this is now will be the fourth round of the study, and administrators have a role to play in sending in an employer's data. What should an employer expect when they contact their administrator to ask to participate in the RAND study? How big a deal is this for an administrator, and what should they expect to hear?
Yeah, so that's an area where we actually made a lot of progress in the last couple of months. And if you have plan administrators such as Anthem, UHC, UMR, Aetna, or Cigna, all you have to do is send your plan administrator literally a 2-sentence email saying that you'd like your data to be transferred. If you have somebody outside those, there is an individual data use agreement and contract for that covers that plan. And actually, we've done a lot of kind of standardizing that language, and so have kind of pared that down so it's pretty straightforward for employers to do.
Excellent. Good. Thank you. Let me ask this question. You mentioned the work that employers might be able to do to make an impact here, and we're curious as a researcher with an interest in this area. You know, how it is that what the actions employers take impact markets, how providers respond, et cetera. Are there any plans to study what's happening in markets where employers, brokers, providers are acting on the RAND study? Any work being done to sort of catalog what's working and what's not?
Yeah, that's actually a very good question. You know, I think as we're thinking about kind of what's the kind of big picture of the RAND study, we've really gone in the last couple of years and saying this is the problem. For me personally, it'd be much better to say, use the data to instead say this is what employers are doing to drive change. And so I think that's where we really want to start pushing on the next round, RAND 4.0. And I think one area that we, again, really want to focus on is some of the work that actually has come out of Indiana, and that Indiana has led to change prices. And a lot of those plans actually went into effect in January of this year. And so we should have some data to be able to actually look at those plans. And that being said, I know that there are many other things that employers are doing. And so I think having this kind of repository of what employers are doing to drive their benefit innovations is something that really I think can be a value to the study. And then I think it's also important to share that information widely. And so if a given employer is doing something by themselves and hits on a really successful program, then I think it's critical to share that with other employers so they can learn as well.
Exactly. And Chris, just to plant the seed, many of the things on your employer to-do list are baked into our strategic plan and are things that are already underway or will be getting underway. And so we'd be excited to share the experience that we have here in terms of what's working and what we're learning. It's important. Let me ask a question also that's come in. What did the study reveal about the drivers of Wisconsin's high healthcare costs? Were you able to discern through that study whether the high prices were more associated with utilization or high price or a combination?
Yes, that's also a good question. And so to be clear, we're looking at just prices, and we are also adjusting for differences in patient population and procedures. And so in our study, it's if say patients at one hospital are sicker or more complex than in another hospital, we've already accounted for all of those differences. But I think there is a big question that the simple question for you to look at and to think about from the results is why are prices in Wisconsin so much higher than Illinois? I lived in Chicago for a bunch of years, and it's not necessarily a low cost of place of living, and there's lots of expenses for operating businesses in Chicago, and range in patient populations, et cetera. And so why is it that prices in so Green Bay or Milwaukee or other Wisconsin areas are ranked so much higher in our study, the HCCI study, or even the cost report data? And it's there's not a clear answer, and in Chicago and in other parts of Illinois, there's probably a little bit more competition between hospitals. It could be that the employers in Illinois actually push a little bit harder on prices that are being negotiated on their behalf. And so I think it's important to think about what is going on in Illinois that's different from Wisconsin, and what can employers and purchasers in Wisconsin learn from their neighboring states.
So just taking off on that, one of the prevailing messages in Wisconsin is that we have a number of large integrated delivery systems, and while the unit price here may be higher, the overall price, the overall cost, the total cost is lower because providers are using fewer units to deliver care, so they're more efficient. So unit price itself shouldn't be a big indicator or a big concern. It's more about the total price. What are your thoughts about that?
So my shorter answer is you can't have a total price without price. And price, if you think about how you purchase anything else in life, and you're thinking about how much is this going to cost me, the first thing you think about is what is the price and how does this price compare to something else. And I think that's true across the board, and especially true for healthcare, where frankly we have very little data on price until now. And if we look at kind of other studies that have looked at what explains variation in overall spending, and so that's kind of price times quantity in different markets, a host of other studies have found that for the commercially insured market and the privately insured market, it's actually not differences in utilization that drives the main difference in spending. It's really differences in prices. And so I think that there are opportunities where employers can look at prices by themselves, and in areas where there are huge variances in prices, think about if there's, is it even feasible that there would be that much difference in utilization that would explain difference in prices. And so if, for example, if we see areas where hospital prices are, 100% of Medicare different from one another, is it really the case that one hospital, a lower price hospital, is really going to be performing 100% more surgeries or 100% more other services that's going to account for that difference in prices?
Thanks. I've got a couple questions that pertain to what people can do with the data. So, and maybe Chris, think about this from the perspective of what's available on the Employer Price Transparency and RAND website. So can people compile the data regionally across states like Northwest, Southwest, et cetera? Are you able to sort the data in that way? And then I have another question after that.
Yeah, so the data on the RAND website actually lists by individual hospitals, and so you can see at the individual hospital level, and I believe we also have the address of the hospital and the town that the hospital's in, and so you can see regionally what do prices look at the individual hospital level.
And the second question along a similar line is that Wisconsin has its own quality measurement and reporting initiative. The Wisconsin Collaborative for Healthcare Quality is one. There are, I think, are others. But would we be able to take the analysis from the RAND study and pair it with quality data from other sources?
Yeah, I think that's actually a really good thing to do, and essentially what the state of Colorado did, or the Colorado Business Group on Health did. So they as a business organization have been collecting very detailed quality data, but didn't have prices, and so they were actually able to combine the price data that we reported with the quality data that they've been collecting, and actually reuse that to say here are the high value hospitals. And just to discuss that a little bit more, and then also go back to the previous question. So as we're thinking about kind of the source of data, I think it's important to think not just kind of what is, say, the RAND study or different quality sources of data separately, but really to combine them into the two. And so, for example, there's a BHCG report this summer that looked at actually how differences in provider organizations integrated delivery system explain differences in overall spending and quality. And so I think that's actually found very little to no relationship. And so I think that's an example of where pooling kind of as much data as you can get your hands on to really drill down into these questions is important.
I have two last questions. One is, has a similar study been completed for prescription drugs?
That's a really good question. We have not looked at prescription drugs for two reasons. So if we look at the kind of chunk of the pie, hospitals account for about 45% of employer spending, and prescription drugs are at about 9%. And so just where we should focus our efforts is probably more on the bigger chunk of the pie. And then two, we have been able to get medical claims data, but not data from pharmacy benefit managers or other pharmacy data. If that data is widely available, then I think that's actually a really good area to look at, and not just kind of traditional drugs, but also things like infused drugs or specialty drugs.
Good, thank you. And then the last question is, if an employer participates in RAND 4.0, will they be able to see their data either in a report or online to allow them for more insight? So maybe you could talk about the private report.
Yeah, that is a good question. So we do have this private report option, which we did for 2.0 and 3.0 and continuing for 4.0. And that allows you to essentially see how much you have, among your employee population, what do prices look like for your patients and your employees and their families. And so that is a report that gets sent to you as an individual employer. It describes a lot of the same information in terms of at the hospital level, this is how much you're paying. It also looks at trends in prices for inpatient and outpatient services. And then also does some kind of high level calculations that if you as an employer, based on what you are spending now, we're able to think a little bit more about prices and bring prices down in a couple different ways, how might you as an employer potentially save. If you're an employer who participated in RAND 3.0 and got a private report, we are, those actually, I got an email this morning, those finally finished running, and so we're in the process of sending them out.
Excellent. Chris, thanks. Just maybe some parting thoughts going into the break. I first of all want to thank you and thank the RAND Corporation and for this work. It is providing new insights and energy across the country and motivating employers to act in ways that I think few other things have done. So I think this is really an amazing moment, and coming at a time that in itself is unprecedented with the COVID pandemic. I think the thing that I think about is that with this information, it allows us to not only have a motivation to act, but to find new partners. So it might be easy to look at this data and want to fix blame. And that would be easy to do. That would be tempting to do. But I think instead, during the pandemic, we know that healthcare facilities are challenged. We also know that the business community is challenged, as are all of us as consumers, as people. And so I think this is a time to find partners. And just speaking on behalf of the Alliance, we welcome the physicians and the hospitals who understand that healthcare is becoming unaffordable and who want to work together to ensure that there's high quality care available to people that they can afford. So we're looking forward to continuing that conversation. And now we'll take a 10-minute break. Thanks again, Chris.
Thank you.
Welcome back, everyone. This next part of our program focuses on what the Alliance is doing to help you control healthcare costs, what we all can do together through the Alliance to impact the data that you just saw. So Kyle Monroe and Melina Kambitsi are going to be sharing that information. Kyle is our Vice President of Network Development and Provider Relations, and he and his team are responsible for building our provider network while also seeking better ways to pay for care and assess quality to achieve the goal of high-value healthcare. Melina Kambitsi is our Senior Vice President of Business Development and Strategic Marketing, and she and her team are helping to ensure that the cooperative continues to grow and thrive, so we're able to serve our members and meet our mission. Both Kyle and Melina joined our team in 2017, and I say this with fondness, life has not been the same since. Melina?
Thank you, Cheryl. Good morning, everybody. Need to make certain that I can move the presentation. Okay, that's fantastic. Okay, so good morning, everybody. Yes, Melina Kambitsi here. Life has not been the same, and actually life has not been the same these past 8 months, right? That's the understatement of the century. As Cheryl said, we miss you all tremendously, the energy, the friendships, the talks, the discussions, the lunches, etc. Although I have been one of the more lucky ones because I've been seeing many of you on video calls, and actually I've visited a few of you. So with that, I'll turn it over here to Kyle in a second, but just wanted to set it up a little bit before. So we are very proud to be representing, as Paul Meyer said this morning, 295 employers, 110,000 of your employees and their families. And our mission is to work on all of your behalf to provide you with high-value healthcare. And we do so through our 4 core drivers. We actually introduced these 4 core drivers: transparency, payment reform, provider network design, and benefit plan design last year, almost exactly a year ago, at our last year's, the 2019 annual meeting. So our CEO, Cheryl DeMars, and Dr. Chris Whaley of the Rand Institute in the first part of this presentation today, or this meeting today, talked about transparency. And so we will move on now to talk about payment reform and provider network design. And actually, Cheryl said, I took notes as she was speaking. She said that step 2 of our collective work is using cost and quality information to buy care. So Kyle will lead us through a discussion of how we use this information, cost and quality, to purchase care on your behalf, to do our contracts. And then since the RAND study launched on September 18th, I launched first in Indiana on the 18th of September. The 24th, we had 2 webinars with the Milwaukee Business Group and with WMC. We've already had employers that are getting in touch with us to help them with tiering their network, the alliance network that they're using. And actually, we're working with many of our broker and TPA partners to bring transparency and benefit plan design to our markets. In fact, a shout out to one of our great TPA partners, Oxient. We're working right now to integrate their care navigation tool, which is called Focus Health, with our tools and information. So I will be talking quite a bit about benefit plan design, and then also as part of the benefit plan design, direct primary care offerings as well.
Thank you, Melina. Good morning, everyone. My name is Kyle Monroe. I'm the Vice President of Network Development and Provider Relations at the Alliance. If these next 2 slides look familiar to some of you, it's because we introduced these topics at last year's annual meeting. They're also directly related to the work our friends at the RAND Institute are doing. The folks at the RAND Institute, Chris specifically, and his team have spent some time with us over the last couple of years, and it's really been helpful for us to develop the capabilities we've been able to develop at the Alliance. We'll talk more about what that means for Alliance employers in a minute. Someone once shared with me a Chinese proverb that the best time to plant a tree was 20 years ago. The second best time is now. And I've had that thought in my mind as I've learned and as I've grown into healthcare and learned more about healthcare pricing. I have the same thought when I was preparing this to talk with you this morning. Why isn't it simpler? Why can't we predict what things will cost? Why didn't somebody do something about this a long time ago? It wasn't until I joined the Alliance that I realized some organizations weren't sitting around to wait to plant their trees. At the Alliance, we believe healthcare pricing should be simple, predictable, and transparent. This is our core purchasing philosophy. It's really not that complicated. Simple for purchasers and consumers to understand. Easy to compare rates from different provider organizations. The mechanics can be complex, but we need to be able to communicate and translate that back in a simple way to employers and purchasers. Predictable costs for services, predictable medical costs year over year for plan sponsors, and predictable expectations so patients know what they're going to get and what it's going to cost when they go see the doctor. Transparent data, transparent cost information, transparent quality information. These are things that are at the core of everything we look to achieve at the Alliance. And again, it starts with simple, predictable, and transparent. In discount models, plan sponsors have little to no transparency into what they're paying for until after the services are rendered. If you think about that, I mean, would you ever go buy a car where your local car salesman said, okay, we're not going to tell you the price, you can't see or test drive the car, but you can buy it for $30,000. How many of us would do that? Well, we do it in healthcare every day. And this comes back to the why. Why do we do that? Why have we accepted it for so long? Well, I can tell you at the Alliance, we don't. With your support, we are changing the way healthcare is paid for so that it's simple, predictable, and transparent. And I just want to say thank you to the RAND team from my area, and it's been really helpful to work with Chris and everyone there. And I think it's really made us stronger as an organization. So a shout out to the folks at RAND one more time from us. There we go. And this is why it's important. So the RAND study is only a few weeks old, and there are already organizations trying to discredit the results. They say that, contracting as a percent, paying commercial prices like Medicare is impossible, or that it's inappropriate. The methodology is flawed, that nobody will ever agree to these things, and this is a waste of time. Let me be very clear. Anyone who discounts or says that these things are not possible is flat out wrong. I know they're flat out wrong because this is exactly what we're doing at the Alliance. We're negotiating reference-based contracts benchmarked to Medicare. As a reminder, Medicare is the largest purchaser of healthcare in the world. We get close to $1 trillion a year. That's trillion with a T. And Chris talked about some of these components, and so I won't go over everything, but some of them I do want to hit again because they're really important to why we're doing what we're doing at the Alliance. Using a percent of Medicare resets the starting point. What do I mean by that? Traditionally, commercial health Medicare has started at the provider's billed charge, and then we negotiate a discount. The problem with that is the provider's charges can be set to whatever they want. And that has led to the anomaly in healthcare pricing that we have today. Using a percent of Medicare resets from starting at billed charge to starting at something with a rational explanation, and that's the Medicare base rate. Medicare's base rate starts with cost, right? And you heard Chris say, providers have to submit a cost report every year to Medicare, and that's the provider telling Medicare, here's what it costs me to provide those services. So we already know we're based we're starting over a new place. We're starting from cost, which is where we want. There are two components to the Medicare, or there's a few components to the Medicare price point, but two of them are really important for us. The base rate that I just talked about, that started at cost. Then there's also some provider-specific discounts and adjustments, sorry, not discounts. And Chris talked about some of these too. They're things like wages, geography, if something costs more in one geography versus another. So Medicare adjusts for those things. The other piece that Medicare does is they have value-based components. Two examples of this would be 30-day readmissions and central line infections. So providers, if they have high amounts of central line infections, which is the central IV line that goes in if you're admitted to the hospital, those can get infected. And if you have high numbers of those infections, then providers are dinged and Medicare reduces their payment. Same thing with readmissions. If providers have high readmission rates, then Medicare reduces those. And so those are important pieces because it adds value, right? We want providers that take care of people well. And if they have a lot of readmissions for Medicare patients, it is safe for us to assume that translates to the commercial population as well. So, and I think something important to remind everyone is payment reform is a journey. And while many employers aspire to this journey, the Alliance has been doing it for 30 years. It started out with inflationary controls, which limited the amount that providers could increase their billed charges year over year. And that's really where we started. And the Alliance was founded to begin to do some of these things. I'm proud to say that as we celebrate our 30th anniversary, we're leading again. I'm happy to report that in fiscal year 21, which remember for us starts in June, over 80% of claims flowing through the Alliance's system are repriced using Medicare-based contracts. That means 8 out of every 10 claims you and your employees pay for are benchmarked to Medicare in some way. That number continues to go up, and we are seeing more and more providers come to us to talk about this opportunity. So again, it can and is being done by the Alliance. In general, Alliance contracts range between 150 and 300% of Medicare. As you saw in the RAND data, prices vary greatly across markets and sometimes for valid reasons. The Alliance network is no different. Pricing and variation in pricing both need to be solved for. Pricing needs to go down overall. And Alliance contracts aren't that materially different, at least historically. And this is one of the things, these are both things we're working to change. The Alliance team continues to work on your behalf with our provider partners, but simply cutting prices to the bare bones isn't the right answer. We need to find collaborative solutions that reduce costs, protect plan participants and the plan sponsors, as well as preserve access to high quality healthcare. Medicare-based agreements are a good start, and this is what we've been doing a lot of work on, but they're not the end goal, not by a long shot. You know, Medicare-based agreements allow us to take the next step and bring a lot of value, like Chris was talking about, things like transparency and being able to compare providers. Those are critically important for us to be able to move the needle, but it ultimately doesn't move accountability all the way to the providers, which is where we want to be. But Medicare-based agreements are a step along the path. Medicare-based agreements are going to allow us to move towards more sophisticated agreements that involve providers taking risk on the financial performance of taking care of those people. It's called total cost contracting. You heard Chris talk about it as global budgeting, and the concepts are similar, and we're just using different words. A little bit more about that, and I think this is important to speak some because this is where we're going, and this is where we want to get to. Total cost contracting, as I'm using it, refers to transferring the financial risk to the entities providing services, meaning to the providers. Think about it like managing a budget. So fixed payments at regular intervals over time, and then providers are, they've got their pot of money and then they have to take care of the agreed upon patients with that pot of money. So it really is about them budgeting and asking them to work on a budget. Another way to think about it might be like a subscription service. So like something like you'd pay for Netflix at home, where you pay a monthly fee, and no matter how much Netflix you watch, if you watch an hour or if you watch 100 hours, you're paying the same fee. Melina's going to talk a little bit more about how this works specifically for advanced primary care, but there are more applications as well. It requires robust and transparent data and analytics, as well as a more intimate relationship with providers. This is for a provider to take on risk. It takes this is an area that they've never been in, and so we need to be able to provide actionable information in order to get them to agree to these things. The other thing total cost contracting allows us to do is incorporate actionable quality data. We want to build on the Alliance's strong history of focusing on quality. It started with a program called Quality Counts, where we were publishing scores for providers in the public. Took the next step with Quality Path, and that was our first attempt to pair payment with quality. The next iteration really is this total cost, and it's really the next step of our quality journey. I used the word actionable, and I use that on purpose. The word actionable is defined as giving enough reason to act, and that's exactly what we want. We need information that promotes action, actionable for patients because they know what doctor to choose or what hospital down the street. They also would want to know if I go down the street, I might have a 15% higher chance of readmission than if I went 20 minutes down the street. So it helps just to understand and then take action on that. Actionable for providers and clinicians because it gives them access to new information that will allow them to improve the care they provide. It's also actionable for employers because it will allow you to design more innovative benefit structures for your employees that reduce costs. And we'll talk more about that in a minute. The metrics are also actionable for the Alliance because it allows us to incorporate them into our contracts and network design decisions. In order to do that, we must first define and measure those things that are most important. How well managed are your patients with chronic disease? How often do your patients avoid surgery altogether because you, the provider, helped find it less invasive and ultimately less costly treatment? What is the functional health status of your population specific to spine care? These are important things to know if we want to understand and if our expectations as purchasers are to be met. At the end of the day, we get what we pay for, right? And we've heard Cheryl say that early on. Therefore, we must make payment contingent on meeting our expectations. We can't manage, or if we can't measure, we can't manage. And if we can't manage, status quo remains unchanged. So that's a summary about our payment reform journey that we're on, and we are on it. Now I'm going to talk a little bit and shift to network design. And there are two axes to network design. The first is network growth. And as an aside, network design is really about changing who we buy from, right? So think about payment reform is how we buy, network design is who we buy from. So one component of that is growth. So consistent, we're always in the process of monitoring where employees on your plan are going, and we're trying to make sure that we've got all of those providers under contract and covered that makes sense. Our membership is growing, so the network has to grow. We don't just grow the network for growth's sake. I mean, that's not what we do. And as you heard Paul say, we're not an organization that's out to take over the world. We're out to serve, and we're out to work with employers to change the dynamics in healthcare. We find high-value partners that add value to employers and then facilitate those relationships. I can tell you firsthand, providers call us from all over the country looking to join and to work with us. But just adding a provider isn't helpful unless that provider brings value to you and to your members. Network design is more than just adding new providers, though. We're also focusing on overhauling long-standing agreements to drive more savings. And that means focusing in areas that were already shaded on this map. It is incumbent on us to continue to innovate as well as can add providers to our agreement. When we talk about innovation inside of network design, we at the Alliance call that smarter networks. The future of network design means building smarter networks, right? And that at the Alliance, our smarter networks are designed to serve as a platform on which employers can innovate and provide more innovative benefit strategies, right? And so what does that mean? Right, we've talked to a lot of employers and we're trying to align all the incentives for all the stakeholders here. Employees want options to high quality providers. They want to pay as little as they can. Employers and plan sponsors want to get the best outcome for the lowest price, right? And providers want to work with employers. Well, some smarter networks also promotes those high value providers where quality is good and costs are lower. I'm going to talk specifically about the newest edition for 2020, which is the Alliance Premier Network. The Premier Network is not a narrow network. It's a preferred arrangement with certain providers that results in lower prices if patients choose to use that provider. It does not eliminate any existing provider from the network. So patients are still protected by in-network alliance contracts if they choose to see other network providers. This is an important distinction and something that makes the Premier Network unique for alliance employers. When we developed this strategy, we had 3 goals: reduce costs, remove barriers to care, and promote high quality care. First, we were able to negotiate rates for providers in the Premier Network that are 15 to 30% lower than the Alliance Comprehensive Network. Second, according to a study published in the Journal of American Medicine, 70% of uninsured patients, so this is people with insurance, report delaying or deferring treatment because of the financial burden. Okay, that's not helpful. If we've got, so how do we solve for that? Well, plan sponsors have a role to play here as well. Lower unit prices allow employers to offset the out-of-pocket costs for plan participants, and we'll talk a little bit more about how you do that in a minute. Finally, providers in the Premier Network have agreed to integrate clinically. And I think this is significant because I'm going to tell you why. Because it sounds like an easy thing. Well, connect your systems. And I can tell you from spending about half my career working for provider systems, it's not. It's labor intensive and it's costly. But the providers in the Premier Network have agreed to integrate clinically so that there's a free flow of clinical data, right, to support patients as they move from one provider to another. It also improves care coordination. So providers, if patients are receiving care from multiple providers or multiple organizations, we've got a digital connection. It also means fewer duplicate services because there's more transparency into that patient's record. So that, if you were seeing a provider up in Marshfield, and that they transferred you down to let's say a UW, there wouldn't be a need to replicate anything done at Marshfield because we've got clinically integrated data. So what you see in front of you is an example of the Premier Network design benefit. So how does an employer get access or participate in the Premier Network? In order to use the Premier Network, an employer must reduce out-of-pocket costs for plan participants for using these providers. That can be achieved through using benefit tiers. The requirement for the Premier Network is at least a 10% differential in out-of-pocket costs for the patient. As you can see on the screen, in this example, that's a 10% differential in co-insurance, and then this employer decided to make those. You can see how they decided to change the deductibles. Employers can certainly make these tiers bigger. Make the differences between the tiers larger, and and I think what we would see is if you make the tiers larger, you'll see more migration to and utilization of the top tier. The 2 provider systems in the Premier Network are Marshfield Clinic Health System and the University of Wisconsin Hospital and Health System. As you can see, all the providers, locations, clinics, hospitals, and all the affiliated organizations with those 2 systems are included in this Premier Network. Employers are not restricted from offering other high-value services to enrollees. This includes DPC, so advanced primary care, bundled providers, a few of those examples might be Novo, Twin City Orthopedics, Ortho Illinois. So those are some of our bundled providers that I know many of you are aware of. And if you'd like to talk more specifically about how to do these things or how these things all interact, send Melina and I an email, and we'd be happy to sit down and talk about your individual situation. Melina, if you're talking, you're on mute.
I am not on mute and I'm not talking yet, but you know, I will send everybody a picture of the command center here. I have 5 computers in front of me. It's not always that easy to navigate all of them. But what we would like to share with you, and let me make certain that so what we would like to share with you is a Premier Network savings projections for one of a large customer. This is actually the data of an actual customer of ours, an actual client of ours. This is a large client, primarily in the greater Dane County area, Madison and the greater county area. And so the total bill charges for this customer are 30, in other words, they get the hospitals, the systems bill them $32 million. The repriced contractual amount is $19 million. So today on this comprehensive network, they have been enjoying a discount of 37.6%. As much as we don't like to talk about discounts, we're still using them. Soon, I hope in my lifetime, we'll stop using discounts and we'll be talking about percentages of Medicare. But anyway, so the total savings for this client for the comprehensive network is $11 million, almost 12. If this client was to move to the Premier network, the savings over the comprehensive network would be an additional $2 million. And the discounts would go, so 20% more in savings, and the discounts would go from 37.6% to 47.2%. And you see that the way that we calculate, that's up to an additional $2 million. The way we calculate that is we look at the systems that they use outside of UW, and we move the care, we move the utilization of systems outside of UW into UW. And then there is here another category called other, because as we know, critical access hospitals, we can move all of care into UW. So we use a very specific geographic consideration in terms of how to move the care. So you can see an example of what is happening here. Thank you. So in terms of network flexibility, here's another example of an employer of ours who is actually using this network design, or at least part of this network design. And we're in tier 1, this employer is putting non-emergent schedulable procedures such as PT, imaging, knee replacement, colonoscopies. Then also in that tier 1, they have providers such as their on-site clinic, which is in this case Cedar Ridge Clinic, and some specific contracts that we have for them: Optimum PT, Diagnostic Radiology, Twin Cities Orthopedics, Summit, Minnesota Gastro, Novo. So they put all shoppable procedures in tier 1. Then tier 2 becomes specialty care and the emergency care at the Alliance. And the specific providers that they're using are Marshfield, Prevea, Cumberland, and Oak Cliff. Then tier 3, and you can tell from this example that this employer is in the north of our great state. So for tier 3, for other systems that exist in their geography, they use a RAP network. And then what the Alliance is introducing, and I'm not suggesting that this employer will actually be doing an out-of-network reference-based pricing, but one of the solutions we're introducing is a partnership with AMPS and having the ability to use reference-based pricing for out-of-network. So AMPS is otherwise known as Advanced Medical Pricing Solutions. They're an RBP solution, and they can realize significant savings if utilized as an out-of-network for out-of-network charges. They use what they call a reference-based reimbursement. I'll talk about that a little bit later in a few minutes. They can average between 65 to 72% of savings for the out-of-network medical bills. And being on the more mature side of RBP vendors, RBP companies, they have a very large database which they use, and actually they've shared with us, they've shown to us as well. What that historical database does is it gives it like similarly to how the Alliance has a lot of cost information because we own the contracts for 30 years now. They similarly have historical data, and they can derive the best possible price specific to the provider systems. So meaning they don't go out writing contracts that look like 110% of Medicare, whether you're in Texas or whether you are in, or the employer is in Wisconsin. So they also, what's really impressive, they also collect data on the number of times a provider declines their RBP methodology. And so we know, the employer knows, the broker knows, the TPA knows ahead of time if the specific provider is high risk at rejecting the price. So they know at which point they need to negotiate. In the case of the partnership with the Alliance, they bring in our own negotiators to negotiate prices for mutual clients, and before the patient gets drawn in the middle and gets balanced billed. So a little bit more about AMPS and how we work together. So the most basic level, the Alliance and AMPS provides the RBP solution in the network. All the discussion on the networks that Kyle discussed a few minutes ago. We also provide data visibility, both the data, the historical data that AMPS has been collecting. In fact, they call this a dynamic approach to RBP. We together do a lot of the provider relations. And then within the provider relations, another very big differentiation in this relationship is that there is a medical bill review. So AMPS has a physician panel that reviews each claim line by line for billing accuracy. And that could translate to an additional 7 to 10% savings for employers. There is an on-demand portal. So both employer broker advocacy, but of course member advocacy as well, to help patients as they navigate through the system. Then at the AMPS level, care navigation is very important. That's something that AMPS is providing using both their data, but also the Alliance data. We'll talk about care navigation here. It's very important. I know many of you are asking for how to best navigate our patients to a small list of specialists that are high value, meaning high quality and low cost. So we'll talk about care navigation when we, in a few minutes with direct primary care. Also, AMPS provides legal and fiduciary protection. And lastly, then the Alliance comes in with direct primary care. That is a very important component, we think, and because as long as we have independent primary care, we can take care of the navigation of our patients, of our employees and their families into the rest of the system. So with that, let me talk a little bit about advanced primary care. And there is many ways. I want to define advanced primary care first, and then I also want to say that there are many ways of achieving advanced primary care. One that many of you have heard over these past few months in the summer is direct primary care or shared site clinics. But also we have a lot of independent physicians. There are many critical access hospitals and many systems that we intend to work with to bring to the market advanced primary care in multiple forms, not just shared site clinics, but in multiple forms. We know that care starts at the PCP's office. We also know that over 80% of patients with chronic conditions see their PCP multiple times a year, minimum 2 times a year, but often much more than that. And that makes the PCP visit the most prevalent visit in the healthcare ecosystem. And because primary care is the least expensive type of service vis-a-vis specialty care, it also is the more affordable type of care. What happens to our current systems right now is that misaligned incentives, lack of integration with behavioral health, which we at the Alliance and others think is very important, and lack of appropriate referrals drive up costs, and they compromise the effectiveness and also the patient satisfaction. I want to explore what are the characteristics that make primary care advanced, and it starts really at the patient level, it ends with the employer. So first and foremost, advanced primary care needs to offer enhanced access to patients. More time with patients means better care. It also means that the patient is known to the primary care provider as a whole person. All of the questions, all of the concerns could be discussed at a visit that lasts more than 10 minutes. So we believe in 20 to 30 minute type visits with primary care physicians. And then if we look sort of in the middle of the characteristics is the characteristics on behalf that the providers need to bring to the table. So decision support for evidence-based medicine. Also risk stratified care management, making certain that the entire person is taken care of, and also knowing that high-risk patients and patients with chronic conditions, they tend to need more care, more hand-holding, making certain that they visit the specialty care. They follow the referrals of the PCP. They follow the RX treatments, etc. So that risk stratification is very important, as well as, so here comes care navigation again. That care coordination and that care navigation is very important. We need to be able to be selecting a careful selection of specialists. Then organizational infrastructure, meaning the analytics and the data warehouse, the databases, to be able to support, connect with specialists, utilize EMRs, and support the entire continuum of care. I mentioned earlier that behavioral health integration is also very important, and it's something that we're seeking in promoting, in bringing direct primary care to our markets. Then it ends, these characteristics of advanced primary care end with the employer, and we always need to keep the employer in mind. So balanced compensation, I'll talk about in a second how DPC gets paid right now. But moving away from fee-for-service, going to a membership type model is very important. And also very important to help control the cost of care, few referrals outside of the primary care ecosystem. So DPC, direct primary care, which is what the Alliance has chosen to first bring to the market as the first introduction of advanced primary care in the market, is delivered outside the traditional health system typically. It means it has different incentives. It seeks to improve patients' care, health, and also to lower the total cost of healthcare. It's a patient-centered care for the whole family. And as I said, it is a member-based model. So typically no insurance is required and the pricing is transparent. It is typically the patient or the employer, because employers have actually adopted this model, will pay a PMPM, a per member per month, once the patient gets engaged. So it's instead of aiming to generate a lot of specialty care, it exists to generate more health for the employees, and then better costs for the employers who sponsor the health benefits. And as I've alluded to, many of our employers here in Wisconsin, and I'm now seeing it increasingly in Illinois as well, have adopted, have embraced the DPC concept. And in fact, as I've said, we have some excellent primary care providers with whom the Alliance is working. We have chosen partners to offer DPC to our employers. We've chosen partners who can help us deliver this personalized care of direct primary care with the comprehensive infrastructure of the on-site, near-site offering, which until now was available only to very large employers. So we want to be your primary care partners, and it takes the entire ecosystem of the risk side of healthcare, the broker consultants who serve as a strategic consultant with the Alliance, but also recommend to employers. This is something that our brokers and our TPAs need to be talking to the C-suite of the employers, and also the broker consultants help with identifying the right benefit designs for our employers. The employer then sponsors the clinic, promotes and incents the clinic usage to employees, and pays a per member per month fee instead of a bill for each service. The Alliance then works to manage the oversight of the health center and the relationship with the advanced primary care providers. We provide clinic usage reporting to the employer and their broker. We identify the lower cost, high value providers when referrals are needed, and we support employee education to create better healthcare consumers. And finally, very importantly, because the concept is shared site clinics, we have many employers that are not large enough to be able to support an on-site clinic or a near-site clinic. So we prefer to bring to the market the concept of a shared site clinic where multiple smaller employers can come together. And it's our responsibility, it's the Alliance's responsibility to recruit additional employers to share in this primary care offering. Then lastly, the advanced primary care provider provides care to employees and their families. They act as a benefits concierge and a patient advocate. They aggregate data for disease management, utilization management, and care management, and then also integrates reporting with the Alliance for the, and actually often the TPA and the RX for one source of truth. So with that, that concludes, Kyle, why don't you come back on camera? That concludes the presentation portion. But we have lots of questions that are coming through. So several for you. And John Stevens, I'm going to put you on the spot, if that is okay. Great partner in WPS, and he has two very specific questions. So number one, Kyle, Smart Choice MRI in central Wisconsin, will we see them in 2021?
I hope so. You know, we have a really good relationship with the folks at Smart Choice, and I know that they're continuing to look to expand. I think, like a lot of organizations right now impacted by COVID, you know, and provider organizations in particular, you know, there's a need to have PPE, protective equipment, and all those things are tough to get. And so I know it's causing most provider organizations to reevaluate their growth strategies. It is still planned to bring more smart choice locations to Wisconsin, and we'll see how that continues to unfold.
And as I believe you've mentioned, and if you didn't, I would be remiss if I don't mention, Kyle, that there are definitely many providers that are calling us and are talking to us right now. They want to also participate in this tiered Premier Network. So there's going to be different iterations of the Premier Network for us to see. Would you consider, Kyle, asking the Premier providers to agree to white bagging for high-cost specialty drugs?
Yeah, and let me explain to everybody what white bagging is real quick. So white bagging is when, you know, the patient is asked to bring the drugs in from a third party into the providers, and oftentimes providers will say that you know, they've lost chain of command of the drug, and so they won't allow patients to bring those on site because they have not been able to quality control what they're injecting people with, and so that's the pushback. Certainly, we've had those conversations before, and would be happy to work with, you know, whatever provider organizations that are in our network. If we're having, you know, if that's an issue, then we'd be happy to facilitate and have those discussions.
Thank you, Kyle. Another question is, as we saw from the RAND study, UW is a relatively expensive system, one of the more expensive systems in Wisconsin. I actually think that what RAND was showing was that they were relatively more expensive in Illinois, but also up there in Wisconsin as well. So how does this strategy then work here? Because UW is part of the Premier Network. I might want to add here that I did show some of the numbers, right, Kyle, that we saw a 20% additional savings for the client that we showed, and a 10 percentage point differentiation in the contractual discounts, meaning 30, whatever it was, I'm sorry, 37.6 versus 47.2. Would you like to add something to that?
Yeah, and to the asker of that question, that's one of the reasons, and this is what we're doing right now, right? We're finding those pockets of more costly providers and coming up with collaborative solutions to lower costs and maintain access. I mean, and so yes, we realized that, and that's one of the reasons that we initiated those conversations. And I'll say, it wasn't, they've been a really good partner here, and I think you saw the example that Melina provided about the opportunity for employers, and so we're just getting started, and I think we're going to continue to evaluate and build out our own strategies and initiatives. But this idea of we're going to find those pockets of higher cost providers, and then we're going to approach them and figure out ways to lower costs. I mean, that is exactly what we're doing.
And please correct me if my numbers are wrong. I'm the salesperson, so I always go with numbers. But I am indicating in the market that our average Medicare percentage of UW is 167% of Medicare.
Yeah, well, and as Chris explained, that depends on the services. It depends on, but that's the Premier Network pricing. Yes, is as it's modeled is below 200% of Medicare. That's certainly a safe statement.
Vis-a-vis the 350 that I believe that the RAND study was showing. So, and to Kyle's point, this is why he and his team started with our main academic center in central Wisconsin.
And
so,
just one reminder, to folks that, the data in the RAND study it's a comprehensive data set, but it isn't necessarily reflective always of what the Alliance pays. And if, we are a member-owned cooperative, and if you're interested in knowing more about specific prices, specific providers, please contact us. These are your contracts. I mean, and so and we will show them to you. We will sit down, we'll talk through them, and happy to do that.
And so, Kyle, you mentioned that there's many hospitals and providers really across the country that are being in contact with you right now to join the network. And from my knowledge, from our discussions, all of them are coming to us as they want to introduce a Medicare reference type contracting, not a fee for service. So another question here is, can you talk about the hospitals and the providers' reactions to shifting them to a percentage of Medicare?
Yeah, this is interesting because, as I said earlier, I think, there's this belief that providers will never agree to it, and that has not been our experience in the slightest. We sit down and we have a constructive conversation about, our pursuit of simple, predictable, and transparent. And providers, regardless of what they say, are intimately familiar with how Medicare pays them. And so once we kind of get over this hump of, well, it's not, we can agree pretty quickly that it's a pretty good methodology. And sometimes we have to make some adjustments, or there are other things we need to do to wrap around that Medicare methodology to make providers more comfortable. But we have the sophistication and the ability to do that at the Alliance. So they've not been contentious. I'm not going to say, all providers love the idea. I mean, that's not true either. But there's enough, and on my experience, if I had just if you wanted a percentage more than 50% are really gravitating towards something like this, and it continues to, the interest in it continues to expand and evolve, and that's been really exciting for us.
So last question about the Premier Network, and how would it apply to an HDHP, an HSA qualified plan versus a PPO? I can answer this. I can tell you that we are working with clients right now that have HSAs, and they create a second level of, so for level 2, they have a different deductible and out-of-pocket maximum. Please call me to talk about how that might work. But I am seeing a lot of our clients that are interested in this program. They have HSAs, they like HSAs, they don't want to move away from HDHP, and they're making it work. Kyle, where are we looking to grow the network next?
We're continuing to evaluate those strategies, and as I mentioned in the network growth component, first and foremost, we look where you, our employer members, have spend, and to make sure that we've got good contracts in those places so we can support you. We continue to evaluate where there are other employers that are looking for help. So some of the potential markets that we're looking into are down into Indiana, Iowa, expansion further into Iowa, expansion into Minnesota is another option that we're reviewing. And some of this will continue to unfold as we evaluate those markets, evaluate the provider communities, and have some initial conversations with some of those providers. Because as I mentioned, we won't sign a deal just to get a deal. And if we can't get a good deal, then may not be, and if our message and if working with local employers isn't important to that provider, then I don't know that I don't know that that's the right place for us. So those are some areas where we're looking right now, and as I said, we continue to evaluate.
And then I know we're a couple minutes over, but I have two last questions I would like to address. If I'm interested in an advanced primary care clinic, how long would it take to get it up and running? Typically, it takes about 120 days. And then finally, what is the average cost to employers for an advanced primary care clinic? So the model we're bringing to the market, it's $62 per member per month. We are mimicking the DPC membership type model. So the reimbursement really starts once a patient comes to the clinic, not when we talk to them as a patient advocate or for general information, but when they come to the clinic. And it's a per member per month that's capped at a certain level of how many members are in a specific family. So with that, I think we are done with questions. We thank you on behalf of Kyle and I. We thank you very much for your time today. Cheryl, would you like to come back on to finish the meeting today?
Yes, thank you, Kyle and Melina. And as you can see, we are leaving no stone unturned in our pursuit of ways to help you control costs and improve the quality of care for your employees. I mentioned at the outset of our program today that we're celebrating our 30-year anniversary, and it was 30 years ago that 7 employers got together and decided to make a difference in healthcare. We've put together a short video to commemorate this milestone, and we hope you enjoy it. We got started 30 years ago by 7 employers in the Dane County area out of a frustration with their healthcare costs. They had an opportunity to work together to contract directly with doctors and hospitals to get better prices for their employees. The Alliance is a cooperative owned by employers. We work on their behalf to control healthcare costs, improve the quality of care, and engage consumers in their health. From the beginning, the founding employers of the Alliance believed in the importance of having information to compare the cost and quality of healthcare. That's why we took the step of creating the first quality counts report. It was something that hadn't been done before, and it was the first time that hospitals were compared side by side, and that information was publicly available.
We demonstrated that what gets measured and reported publicly tends to get improved.
But that wasn't enough. It wasn't enough just to have information available comparing the cost and quality. It didn't do enough to really move the market. And that's why we shifted our strategy. And instead of just measuring and publicly reporting on cost and quality, we shifted to helping our employers use that information to structure benefit plan designs that encourage employees to go where care is good and costs are low.
One of the things that I believe is important when you're dealing in any arena is being able to find someone that you can trust and not necessarily someone who's just giving you the information because it's self-serving. We're not interested in just paying the least amount. We're interested in paying what I would consider to be the best amount. And the Alliance helped us get some information to do that.
You have to ask yourself, do you control the data or does the data control you? The Alliance helps us uncover all of the aspects of the data.
We started examining the lab costs that we were experiencing locally. By bringing it in-house on-site, on campus, we could have the employee just pop by on their lunch hour and save themselves and the plan several $100s per lab. To be honest, I definitely cannot take credit for the lab service, low-hanging fruit that we grabbed. That was our account manager at the Alliance.
We were creating our own private direct contracts, and we didn't really have any particular expertise. They were mostly handshake types of contracts with people that we knew in our community, and we needed somebody with more expertise in that area to hold those contracts. The Alliance has a larger network. I'm not sure that we would have got it done without them.
Over the last 5 years, our network has more than doubled in size, and we continue to grow very, very rapidly to meet the needs of the employers and our owners.
When I think of the Alliance, I think of an organization that is filled with staff that really care about solving the complexities that employers deal with in health benefits. At the same time, I think they're very passionate about helping patients.
They don't sit still. They're not just saying, oh, hey, we've got this solved. They're looking at some really great things.
The Alliance's role has grown and deepened and broadened in so many ways to move beyond price negotiation, data analysis, to quality health care, to training, to education.
I know I have a group that I can come to be honest about the challenges that our organization is facing in healthcare, and that they're going to help advocate for me, think of things that I haven't thought of myself.
I think the Alliance is in a place in the healthcare ecosystem where we can have a big impact. I think employers working together hold at least a big part of the potential to drive transformation in healthcare. So I have to say, I was here while the video was being filmed by some of the people who participated in that session, and it was fun to have back Chris Querum, our former CEO, Jack Garner, a founding member, and several of our members today. It was a fun process. So I hope you enjoyed that. We are now to our grand finale, which is the Health Transformation Awards. Wendy Culver will be back to introduce this year's awards, but this is really something that our board established in 2015 to recognize those individuals and organizations that are aligned with our mission. And so, Wendy, thanks for your help in introducing this year's award winners.
Well, I'm really honored to do that. And that was a fantastic video, by the way, and it's amazing to see how far the Alliance has come in 30 years. So congratulations to all of us for that. So again, I'm very proud to announce our award winners, but before doing that, I want to mention that the criteria this year have been changed to be more in line with the larger high-value healthcare strategy laid out last year at our annual meeting. The purpose was we wanted to align with the actions that we believe can transform healthcare and acknowledge those organizations and individuals already using them. So, drum roll please, our award winners this year are the Wisconsin Health Information Organization, also known as WIO, Tracy Rothenberger, who is the clinic manager at Nordic Private Care, Matt Ort, Director of Benefits and HR at Merrill Steel, and Tina Hogue, CFO at Advanced Laser. Because this was, of course, not a normal year with all of us being able to gather together in person, We did present the awards to our winners on site and shot a short video, physically distanced, of course, with each winner. So without further delay, here are the very deserving winners of the Alliance's 2020 Health Transformation Awards, and congratulations.
In 2015, the Alliance Board established the Health Transformation Award to recognize individuals and companies who are working toward our mission of moving healthcare forward by controlling healthcare costs, improving quality, and engaging individuals in their health. This year, the award itself is transformed somewhat by focusing on the 4 core drivers that employers can use to get better value care. These include transparency of cost and quality information, network design, payment reform, and benefit plan design. Transformation often starts with a vision, determination, and a why not attitude. In this case, it began in 1991 with a part-time secretary working in occupational health. Over the next 13 years, Tracy Rothenberger would apply her administrative and organizational skills, as well as her vision and determination to improve the lives of her coworkers while helping her employer control their costs. Tracy began in occupational health at Seats Incorporated, soon expanding that program to include wellness and health promotion, and eventually opening an on-site clinic. She was then recruited to a sister company, Flambeau Incorporated, where she replicated and built upon that model, opening Nordic Private Care, or NPC as it's known. Through NPC, employees and their family members can get medical care, pharmaceuticals, physical therapy, massage therapy, and behavioral health care. It was really ahead of its time in terms of providing comprehensive, well-managed primary care. Employees and their family members are getting great care and report high levels of satisfaction. Flambeau has a healthier workforce and is controlling their costs. And now it's my pleasure to present the 2020 Health Transformation Award to NPC, Tracy Rothenberger, and Flambeau Inc. Joining me to accept the award are Tracy Rothenberger and Jason Sowie.
I'd like to say thank you to Cheryl and the Alliance for presenting this award to me. It means a lot to me. I have a very high passion and compassion for what the Alliance does for and with us as employers, and helps us navigate our way to a higher and better quality of care.
What impresses me most about Tracy is that she continually applies herself. She's always staying alert and learning. And as she learns, she's finding ways for us to continue to improve our offerings and the way that we deliver our services through our clinics.
So today I'm at Merrill Steel with Matt Ort, who's the VP of HR and Medical Services. Matt has been resolute in his dedication to his employees, their company, and their health, and he's more than deserving of this award. So Matt has worked to improve the quality and accessibility of health for his nearly 500 employees and their families by, among other things, building an on-site clinic. The first iteration of this on-site clinic he quite literally built with his own hands. Next, Matt realized that many of the healthcare costs for his employees and their families came from services like MRIs, ultrasounds, and x-rays. What he did was quite unique. He purchased an ambulance that he turned into a mobile health clinic that makes house calls to employees' homes. This mobile unit provides accessibility to healthcare services to Merrill Steel employees and their families, as well as saving both Merrill Steel and its employees a lot of healthcare costs by avoiding urgent care and ER visits. Matt has become a leader in healthcare and in his community by sharing his knowledge and his advice with many other employers in northern Wisconsin. And the Alliance Board of Directors is very proud to present him today with this award. I will now invite Matt to join us here on the stage to receive this award.
Yeah, I'm very pleased to receive this award and very humbled that I was the one chosen. But I'm a big believer that when you achieve something, you never achieve it on your own. And there are many people that have been a big part of this achievement that have worked with me. So looking at owners and saying that we're going to have $100,000, $200,000, or $300,000 investment and not knowing how that was going to go was kind of risky, and it was a little scary. Turned out that we had our return on investment very quickly. but you don't know those kinds of things going in. So that trust and that support has been really big on our journey of healthcare.
The Wisconsin Health Information Organization, or WIO as it's known, is a data and information resource that helps us improve the quality and control the costs of healthcare. WIO includes de-identified healthcare claims data on 4.9 million citizens, or about 72% of Wisconsin's population. Using WIO's big data, we're all able to access the same objective source of information, paving the way for collaboration. Dana Richardson is the Chief Executive Officer for WIO, and under her leadership, the WIO team has developed an analysis to identify those citizens most at risk for serious complications of the coronavirus. WIO is making this analysis available free of charge to Wisconsin's health plans as one way to contribute to the management of the coronavirus. It's my pleasure to present the 2020 Health Transformation Award to Dana Richardson and the Wisconsin Health Information Organization. And now we're going to bring Dana in to accept the award and to tell us a little bit more about WIO.
On behalf of the WIO Board of Directors, all of the organizations that contribute data to the WIO, and all of those that use the data, I want to thank you for this very prestigious award. WIO was established in 2008 as a voluntary claims repository, or all payers claims database. The mission of the organization is to provide information to improve the quality, safety, and cost efficiency of healthcare that's delivered in the state of Wisconsin.
Today, the Alliance is proud to award this 2020 Health Transformation Award to Tina Hoig, Chief Financial Officer here at Advanced Laser. Over the past 5 years, Tina introduced Advanced Laser to self-funding and developed benefits that give accessibility to Advanced Laser's 160 employees to low-cost, high-value healthcare. Tina knew that healthcare starts at the primary care provider's office. So determined to reduce healthcare costs for her employer, her employees, and the community at large, she started working with other employers in the region to establish a shared site clinic. Tina has ensured that her employees and their families can have access to affordable healthcare by making routine healthcare, preventive prescription services, and diabetic medical supplies, even insulin, free of charge for all plan participants. Tina has been an outspoken leader in transforming healthcare and is an advocate for other employers looking to do the same by sharing strategies and advice at educational events here at Advanced Laser. Tina, on behalf of the Alliance's Board of Directors, please accept this Health Transformation Award.
I am humbled and grateful to accept this award. It's always gratifying to know that what you're doing is making a difference. But what I hope is that it makes other employers feel brave and bold to take similar steps to improve the outcomes for their employees as well. The one piece of advice that I would have for anyone considering an on-site or near-site clinic, just do it. Don't agonize over the ROI. Don't wait for the moon and stars to align. Just do good by your people, and the rest will take care of itself.
So I would like to add my thanks and congratulations to our award winners. Thank you for the inspiration. I also, in wrapping up, want to thank the Alliance staff. You have done an incredible job of keeping the trains running on time, not only this last 8 months, but the last 4 hours as well. You're all terrific, and I'm proud to work with you. So I want to thank you all for joining us today, and I hope you can tune in next week on October 8th at 10 a.m. when we'll have our health policy webinar. That's 1 hour from 10 to 11. And please watch for an evaluation of today's event in your inbox. We'd appreciate your feedback. Have a good day, everyone. Thanks for tuning in, and stay safe.